today's webinar on Oncology Vision 2025. And with immense pleasure, I would like to invite Program Convener Dr. Sri Gopal Mohanty, who is Senior Consultant and in charge Medical Oncology at HCG Cancer Center, Cuttack, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Yeah, thank you. So very good evening, everyone. So first of all, I would like to extend our heartfelt welcome to all esteemed faculties and delegates for today's CME. And we know that as we are in the era of precision oncology and genomics, so at present, immunotherapy, antibody drug conjugate, targeted therapies are taking the lead in cancer management by improving the survival and improving the quality of life. So yeah, there is definitely a rapid shift in treatment paradigm in cancer management. So to keep ourselves updated with these recent updates, today we have eminent speakers from all over India with us. To start with, we have Dr. Vidya Emin, so who is head and senior consultant in oncopathology from Manipal Hospitals, Bangalore. And next to her, we have Dr. Saurabh Kumar Misra, who is associate professor and head of Department of Medical Oncology at AIIMS Bhubaneswar. We have Dr. Tamajit Chaudhary, who is senior consultant and head of the Medical Oncology Department at Meherbai Tata Memorial Hospital, Jamshedpur. And then we have Dr. Chandrakant MB sir, who is senior consultant medical oncologist from Narayana Super Specialty Hospital, Kolkata. We have Dr. Jogmaya Patnaik, who is associate professor in medical oncology from Kalinga Institute of Medical Science, Bhubaneswar. We have Dr. Nihanti DS, who is consultant medical oncology and hemato-oncology from Saroj Gupta Cancer Center and Research Institute, Kolkata. We have Dr. Pradeep Kumar Mandal sir, consultant medical oncology from Narayana Super Specialty Hospital, Kolkata. We have Dr. Susmita Sadhukaranam, who is consultant medical oncologist from Tata Medical Center, Kolkata. We have Dr. Rohit Bharat, who is country medical lead in India from Guardant Health team, Bangalore. So we have Dr. Somnath Roy sir, who is senior consultant medical oncologist from Tata Medical Center, Kolkata. We have Dr. Sudeep Das sir, who is consultant medical oncology and hemato-oncology from Medica Super Specialty Hospital from Kolkata. So we warmly welcome all our esteemed faculties and all delegates. And I would like to call upon the first speaker, Dr. Vidya Emin, to please start your session on precise pathological diagnosis of HER2-low and ultra-low expressing breast cancer. So, ma'am, please.
Thank you for the kind introduction, Dr. Sri Gopal. Many thanks to Dr. Sri Gopal and AstraZeneca for giving me an opportunity to be here amongst this esteemed audience. So I think this is the only pathology talk for the day. That is how it looks. I'll just start sharing my screen. Is my screen visible?
Yes.
Yeah.
Screen is visible, you are audible. Please.
Yeah. So the topic given to me is precise pathological diagnosis of HER2-low and ultra-low expressing breast cancer. So as we know that we have been dealing with HER2 since a long time, almost since 2007 onwards, and still the controversies around the HER2 scoring, etc., seems to be going on, and it has more or less become a very big learning curve for the pathologists, and this has in fact led to a lot of interaction between the pathologist and the medical oncologist for a two-way interaction, because this is guiding the treatment so drastically, and with the new molecules coming into picture, targeted treatment, it has actually caused a big paradigm shift, especially in our laboratories. So as we can see, the HER2 testing has evolved, and this has evolved over a period of many years now. So the earliest was 2007, and as we see from 2007 to 2025 now, there has been a big shift in terms of the scoring patterns of HER2 which actually dictates treatment. So in earlier days, it was the 3+ score which was dictating treatment, where 3+ was considered positive, and later on we came into 2+, the equivocal cases, where we had to do a reflex ISH testing. Either a dish or a fish test used to be recommended for all these cases. Even now it stands good. And then we had the negative scores where we had 1 plus and 0 coming into picture. But now the main shift is in the 0 and 1 plus scores. And for pathologists who are really not used to separating these scores of 0 and 1 plus, it is a big headache now, because they need to accurately score these cases so that the medical oncologist can give the precise treatment to the patient. So we can see that there has been a big shift between 2018 and the present guidelines. We had the 2023 CAP guidelines coming into picture, the ASCO CAP. And again, modifications on this ASCO CAP has recently come in the part of CAP guideline update, which I'll be taking in my next few slides. In between, we did have the French committee guidelines, the ESMO guidelines, and the RC path recommendations also coming into picture. So, as we know, this is the traditional way that the pathologist is going to score in the laboratory, and this is based on the ASCO CAP guideline 2018. So, 2018 to 2023, please note that the CAP did not make that much of drastic differences. So, we did have the clear cut 3 plus, which was positive, 2 plus, which went in for reflex test, and here we had the 2 plus, which were fish negative, and 2 plus, which became fish or ish positive. And then we had the IHC 1 plus, which was deemed to be negative, and we had IHC 0 again being negative. But we did have some scores coming into picture here, but then the pathologists were really not breaking their head on these 1 plus and 0 scores, because everything was deemed as just negative, and it used to not carry that much of significance when it used to come in for reflex testing or for targeted treatment. So this was a binary classification that the pathologists have been using for the last so many years. Okay, but now we come into the big category of the HER2 negative IHC score zeros and the HER2 low. So what is HER2 low? HER2 low is nothing but our 1 plus, which came into picture, and this was around 2021, 22 kind, wherein a lot of clinical trials came into picture, and we have the Destiny Breast 04 trial, which actually brought in these terms of HER2 low. And then we had the introduction of the term HER2 ultra low. But it took some time for us all to understand what exactly they were asking us to do in the laboratory, and how do we standardize these assays, and how do we report them to the oncologist so that they have a better understanding of what these scores mean. So here we did not bother so much about the 3 plus, because these were anyway categorized as positive and they were eligible for the trastuzumab treatment. But we had the 2 plus coming in, and here the 2 plus ish negative were coming into this pattern of our HER2 negative. But we no more call them as HER2 negative, because these are now called as HER2 not overexpressed in terms of immunohistochemistry, because there can still be low copy numbers which are not detectable by our traditional IHC assays. That is why we now use the term not overexpressed for anything of 0, 1 plus or 2 plus ish negative cases. So that was a big paradigm shift for the pathologist. And in 2021, we had first the French guidelines coming in, where they clearly categorized how the pathologist has to do the scoring, look at the complete membrane staining, whether it is incomplete or partial, weak, etc. And also they did bring about a lot of recommendations on the testing and retesting, whether it is in terms of a new case or a metastasized case, and how do we go about doing these retests on even post-treatment cases. And also the labs were asked to standardize their assays in terms of having arrays on their control, so that the standardization could be easy and adaptable across the laboratories. The next paper was by the RCPath recommendation, which introduced a lot of parameters, or they brought in more clarity for the pathologist to say how the scoring has to exactly be done, and how much of training the pathologist has to undergo for trying to interpret these scores of 0, 1 plus. And they were more looking at the not overexpressed cases, because already the assays were standardized for 3 plus or overexpressed levels. Also, they brought in the clear category telling that only the 2+ cases have to be tested for reflex testing. I can see that there is a lot of confusion that exists in a lot of institutes and amongst pathologists, and where they try to club all the 1+ and 0 cases also for ish testing, but it is not really recommended. The only country which really follows testing of the ish for these not overexpressed cases also is mainly in the Australasia part of it, but not in Australia and not in Europe or in the other continents. So it is mainly that in India that we follow the CAP recommendations, and here according to RC path and CAP recommendations we have 2+ or equivocal cases which go in for our ish testing, but not our 1+ and 0 cases. We then had a paper by the German pathologist in 2023 where they clearly use the term, and they in fact encourage the pathologist to use the term calling HER2 low. So herein we were hit by the term HER2 low. So for what kind of cases do we say it is HER2 low? These are mainly for our 1+ cases where the membrane staining is still incomplete and it is not complete, and it qualifies for more than 10% of the percentage of the tumor cells that are being stained. So these cells were brought into the category of HER2 low, and based on our 2+, these 2+ cases which were negative on ISH could be brought into HER2 low recommendation, but 2+ with ish positive definitely falls into your 3+ category because they are amplified cases. So this was one terminology which was earlier introduced in 2023. So then what did ESMO do? In June 2023, ESMO happily adopted to the guideline recommendations, and in fact recommended that they recognized and identified HER2 low, and hence the HER2 low came into picture. But in the same year, ASCO CAP came out with their own guideline recommendations for HER2 testing. Unfortunately, ASCO CAP did not use the terminologies of HER2 low or ultra low to be put in the reports by the pathologist. We really do not know what was the reason, but it was not really taken into account. What did ASCO CAP do? They did bring about a footnote, which I'll come into later slides. So once the European Committee started adopting, we had a shift where we had HER2 zeros. So we had 2 levels of 0 coming into picture, 1+, which was termed as low, HER2 2+ non-amplified, HER2 2+ amplified, and HER2 3+. So did we stop at this? No. So in 2023, when ASCO CAP gave their recommendations, they brought in few guidelines which helped the pathologists in interpreting these scores better. Only thing that the pathologists were not allowed to do was bring in the terms low and ultra low. So what was the recommendations given by ASCO CAP 2023 was that to recognize the 0 and 1+ staining, the pathologist had to closely observe under 48 objective for these staining patterns. And they brought in another recommendation telling that these low scores have to be reviewed by 2 pathologists who are expert in the field, and hence there will not be any inter-observer variability or bias. So, and they also brought in a good lab practice telling that to have controls of different staining patterns. Earlier we were using the 2+ controls, but now they are telling us to use even 0 and 1+, so that we know that our assays are standardized to such an extent that we are able to pick up these low expressing or really non-expressing levels of HER2. So this was a big shift, and obviously they brought in this footnote in 2023 recommendation, which aligned with the Destiny Breast 4 trial. So Destiny Breast 4 trial recognized the low for TDXT treatment, but it did not, however, allow for treatment of patients with ultra low patterns, and hence CAP brought in a strong recommendation telling that the pathologists have to put in the footnote for the cases where they are calling it as 0 or 1+ or 2+ non-amplified. So this was the recommendation given until 2023. Did we stop with this? No. There were more and more papers which were coming into picture, and lot of papers which aided the pathologists in trying to score better these patterns which we already knew which existed. One of the famous papers was by Dr. Rakha et al. And herein they brought this ICE framework. So what does ICE stand for? I is for intensity, C is for completeness, and E is for extent. So, and then we had 4 different objective levels to be examined for the pathologist. Start with your 4x. If you are able to see 4x intense strong staining which is complete, so and the extent or the proportion is more than 10%, then obviously it comes into your category of 3 plus or overexpressed HER2 new or HER2 positive. Then when you're seeing moderate or weak staining, which is generally observed only at 10 and 20x, and again you look for completeness, so this could either fall into your equivocal category or come into your 1 plus, but for which you need to go further into your 40x magnification and look in for the kind of pattern of staining, whether it is incomplete or complete, and look at the intensity of staining in these cells. The 40x objective was purely used for the 0 category, where we had less than 10% cells and with very faint level of staining. So this is what we currently use in all of our labs. We look at intensity, completeness, and the proportion of the extent, and we do have the objectives of 4x to 40x magnification. Earlier, when we were having before the 2023, we were not giving so much of attention maybe on a 40x magnification to identify between 1 plus and 0 stains, but now even the 0 has to be further subclassified. So this was what was brought out in the paper. All we know, or even the medical oncologists know, is we have 0, 1 plus, 2 plus, 3 plus. But look at the patterns of staining that actually came out in this paper. They tried to analyze, they looked at the percentage positivity, and some patterns they put it as very rare. And we have here close to around 16 patterns of staining of HER2 that can be interpreted by the pathologist if they do a real accurate scoring under their microscopes. So this was a major shift that was happening. And then what happens? We are suddenly hit by the Destiny Breast Trial 06, wherein the term ultra low comes into picture. So we were trying to get adapted to the low, which is nothing but 1 plus reporting, where we had more than 10% of cells with faint or incomplete membrane staining that used to be seen under the microscope. And now we were hit by the ultra low category. So why was this taken into importance? Because in Destiny Breast 04 trial, the ultra low pattern of expression patients were not included. However, in the DB06 trial, we had these category of patients coming into picture for the TDXT treatment. Post the trial, it was declared that even ultra low patients are eligible for TDXT treatment. So there is a complete difference now, and there is a whole paradigm shift that has happened. And now the pathologist needs to call out whether it is HER2 null, ultra low, HER2 low 1 plus, and then obviously you have the 2 plus and the positive categories. So here we were familiar with the 1 plus, and now we had to retrain ourselves and our eyes and mind for the reporting of ultra low and null category. So what do we mean by the null and ultra low category? So this was a seminal paper which came out in 2022, which actually sort of defined to us what is ultra low and null. So when there is no staining at all, which is seen I mean, it's a contradictory statement. There's no staining at all, which is observed in the tumor cells, then we call them as null category. But even faint staining, which is seen under 40x, but less than 10% of cells, comes into the ultra low category. You have the low category, which is more than 10% of cells. So here you have a big problem in calling out the percentage. So especially your borderline categories, here the pathologist has to do a very good scoring. So less than or equal to 10 becomes your ultra low, and here it is 0 staining. So anything between 1 to 10% of staining is called your ultra low. It is as simple as that, but it does not seem to be so simple, because we are seeing a lot of patterns which are seen under the microscope, which many pathologists may not know, and they can wrongly interpret this as either a 1 plus, or sometimes they may not even observe all the cells and they may call it null score, which will actually it is not going to be really beneficial for the patient, because they may be benefited by the TDXT treatment. So what happened to the next thing was that the ASCO cap, even despite all these recommendations, they did not give the ultra low and low recommendation. So unfortunately, we may not be able to incorporate it directly in our reports, but the recent CAP recommendations, the biomarker recommendations for breast cancer, and this was in March 2025, that CAP gave us 0 and 0 plus. So now instead of 0, 1 plus, 2 plus, 3 plus, we have 0, 0 plus, 1 plus, 2 plus, 3 plus. So now what is 0? What is 0 plus? 0 is nothing but your null score, where not even a single tumor cell stains with your HER2 IHC. Your 0 plus is nothing but your ultra low, where you have 1 to 10% of cells with very faint staining of your HER2 new IHC. So this was the difference that they created. So for the medical oncologist, when the pathologist is going to say 0, that means it is null. When it is 0 plus, it is ultra low. It is understood in that manner. So this is a same repetition. The shift that has happened is today we stand at reporting null, ultra low, low, and your ish, because these are the patients, ish negative patients, who are benefited by the TDXT treatment. So this is another repetition slide. I'll not get into this. This is the latest CAP guideline recommendation of 2025 and the previous scoring of your 0, 1 plus, 2 plus. But the the footnote has changed between the earlier CAP recommendation of 2023 to the recent CAP recommendation of 2025. So here they bring in the footnote telling that the pathologists, when they're reporting 0, 0 plus or 1 plus, can put in this footnote telling that in consideration with the Destiny Breast 04 and Breast 06 trials, now even ultra low and low patients are eligible for targeted treatments. So this is the footnote that the pathologist has to bring in, and this is the latest guideline recommendation that we have for the pathologists who are following the CAP recommended guidelines. And NCCN did not stay behind. They have clearly adopted. This is the version 2025, where you have, see that in first line treatment for IHC 0 plus, 1 plus, or 2 plus ish negative, we have the treatment with your TDXT. So this is a huge shift for both the medical oncologist as well as the pathologist, who have to align with each other and then see that we have accurate reports being generated in our labs so that the patient is benefited from the treatment. As you can see, NCCN has still not used the term 0, but I don't think we are far behind. Maybe for all you know, we may have in the future, we may not even look at the scores of 0, and it will in fact ease a pathologist's life. That is what I would want to say. So the main takeaways are that there is a paradigm shift for reporting for the pathologist when it comes to reporting HER2 new. Please do not take it at a relaxed level when you're seeing your 1 plus and 0. They are not the same anymore. They were called negative, but it is better to use the terms as not overexpressed, because these are not seen on your IHC, but still you may have few copy numbers when you do further molecular tests for these cases, and the patient stands to benefit the treatment. So hence be judicious. Now you have the terms 0, 0 plus, 1 plus, which you need to clearly qualify based on your high power examination. When in doubt, please consult one of your colleagues and take their help in the laboratory, because you need to be accurate on the diagnosis or interpretation of these scores. And also look at the ICE, that is intensity, then the completeness and the extent. Use these as steps in your laboratory. And for good lab practice, please use an array of your controls, which will include your 2 plus, 1 plus, and your 0 cases, which actually becomes ideal, so that you know that your assays are standardized. Why am I stressing so much on the controls is, please note that we have currently the assays which are standardized to pick up the positivity or the overexpression. But now we have, since the DB04 and the DB06 has used particular vendor clones for demonstration of these cases or these expression levels, you need to try and use the same clones as possible in your lab, so that you have better reporting. And also you need to know that you will stand on par with your peers in the industry. This is very, very important. And when you are doing or using other lab derived assays or your lab based assays with other clones, you need to have a proper validation before you can actually start reporting. And if you see the papers which are published, there is obviously variation between clones and also the platforms for assays which are going to be used. And please note that for the pathologists, the manual assays do not come close to the automated platforms at all. So when you're doing your manual assays in your labs, so please be aware of the same thing. And the medical oncologists also should know what practices are being done in your laboratory, because the clones and the platforms matter, and also the type, whether it is manual or automated, matters, because there is going to be a variation, and also there is going to be inter-observer variation if the pathologists in your lab are not trained to report these parameters. So please use the footnotes which are available currently for your ASCO CAP recommendations of 2023. You have the CAP biomarker reporting scoring guidelines which are already there, and please use the relevant footnote. And you can delicately convey either in your reports or as verbally to the oncologist, telling that this is a null case, or this is an ultra low case, or this is a low case. So this is left completely to you, but as long as you follow the right protocols, I think you will be generating accurate reports. So thank you very much.
Thank you so much, Dr. Vidya. Taking this forward, I would like to invite Dr. Sri Gopal for his talk. Welcome, sir.
So yeah, so before starting my talk, I just like to ask Dr. Vidya one doubt. That ma'am, it was very good talk, so very informative. So I just wanted to know, because being a medical oncologist, we are really wondering, like many times we are looking for whether it's a ultra low or not. Because as you know that TDXT is like a very, very great drug what we are having in our armamentarium. So some of the cases we are looking for, suppose it is reported. So most of the reports are done before. It is reported as a HER2 low, although the HER2 0 plus, like HER2 0. So the HER2 0 plus, I think in our practice, so far we have not seen, but it has to be implemented as we have already pointed out. So we retrospectively look and discussed with the pathologist that whether it's a ultra low or not. So some of the time what we hear that it's very faint, doctor, we can't comment this is a ultra low or not. So what is your recommendation on that? How many cells minimum, or what is the minimum tumor area to seen to comment that it's a HER2 0, not 0 plus?
Okay, so most of it is core biopsies that we get these days, and post resections, very few cases where we are going to do the HER2/neu, other than when you ask us to do it, right? So for the core needle biopsies, the pathologist has to read the entire section. So for example, now in our practice, in our institute, we get the breast core biopsies, which generally we separate it into two different blocks, because we sometimes you may ask for molecular tests, so we don't want to use the entire tissue. And we may also get metastasis from the lymph nodes. All right. So at the in the same sitting, we do the ERPR HER2 along with the KI on all the tissues. Okay. So we do not try to say that I don't want this block or anything. So whatever tumor tissue is there, even for core biopsies, we do the testing, and all the tumor cells are red. So it is not that you have to be selective on it. So the entire thing is taken into account. Sometimes when there is a lot of necrosis, we discount those areas, but other than that, we do not leave out any tumor cells. So everything is taken into account. And in this, if we have, so say for example, patient has bilateral tumors, okay, right breast and left breast, so right breast is scored separately, left breast is scored separately. But otherwise, if it is the same breast, then you have one single score coming in. And like I said, we have the percentages of scoring that is there, and then we do the calculation and put it in there. Nowadays, there are some artificial intelligence algorithms which are coming into picture, but right now I don't think any vendor has officially launched them, because most of them are into trial basis, because they are trying to generate data. All right, so they need slides which have to be scanned and annotated by the pathologist. So this work is happening in the background. So hopefully in a year we will be seeing some algorithms being launched which will actually aid the pathologist. But again, we are now taking part in various sponsored EQUAS programs, so which will help us in generating more accurate scores. So at our level, we are reporting 0 plus, and sometimes our medical oncologists are asking us to go back and see the slides. But the problem is, sometimes these slides fade over a period of time. So whatever color we put in the slides can fade. That may cause some hindrance. But of late, we have taken out slides which are like 3 or 4 years back also. We have not had so much of issue. So wherein we are able to tell you whether it is 0 or 0 plus or 1 plus, that can be made out. So with the new training recommendations and the platforms which are available, in fact, the pathologist can go on to few online programs which are available, and there you have virtual slides. So through that they can get trained. And 0 plus, I agree, is difficult, but now we are starting comparing blind observer comparison in the lab only between two pathologists. So that way we are trying to bring in more accurate scorings. So this is something that can be done. But 0 plus we have started reporting, so we are not holding it back anymore.
Okay, thank you. So one more point, would you like to comment on the thing that any difference between reporting from whether you'll ask to take a sample from node or from liver or from the breast itself in a recurrent metastatic setting?
Bone will be a difficult thing. It's always a challenge for us because of decal issues. But which lymph node should not be a problem for us in assessing. So it is equally good. So and liver is also, I mean, any metastasis front is actually good, because I somehow am biased to that, because you do not know what are the kind of molecular alterations, and you yourself know that a 0 can become a 0 plus or a 1 plus can become a 0 while during treatment and things like that. So there is going to be that variation that is going to happen, and it is always nice to know what is the metastasis front. The molecular profile of the metastatic front is a very interesting aspect, and I think you should not shy away from testing the metastatic sites. That is very, very important.
Yeah, thank you, madam.
Thank you.
So hope my slides visible and I'm audible.
Yes, sir.
Yeah. So very good evening, and I'll be talking on multi-marker test for recurrence risk prediction in hormone receptor positive early breast cancer and the data of can assist breast test. So when we are managing the early breast cancer, particularly hormone receptor positive, HER2 negative, so many times we face challenges in our resource limited setting, that how to choose whom to spare chemotherapy. There will be a significant proportion of patients who actually don't need chemotherapy in this early breast cancer setting. So definitely, what we are practicing in most of our patients is like based on the age and grade of the tumor in the early breast cancer setting. So IHC4. So all those parameters not always holds good or enough, because even after using IHC4, we may be over-treating the patients. So many of the patients, although we have these Oncotype DX, Mama Print, Prosigna, EndoPredict, all this genomic recurrence score testing, but these are tests that actually lead in the west part of this world, and whereas this is having so much of limitations in our so far as India is concerned. So tumor biology is most important before the TNM staging, when we are talking about the risk of recurrence and classifying the risk, like patient group, whether to put them for chemotherapy or not. This is the case, like we can see in even in low clinical risk, we can get high prognostic, like high risk group. So even in low clinical risk, like T1 clinical T1, T2, N0, or low K67, even if postmenopausal, still there will be tumors who will be at high risk of recurrence. On the other side, there will be again in high clinical risk, like grade 3 tumor or N1 disease, 1 to 3 nodes positive disease, grade 3 tumors, premenopausal. Even in those high clinical risk group, there will be certain substantial proportion of patients where we don't need to go for chemotherapy. So they will be low risk as per the prognostic risk scoring. So whether, apart from those Western data, so whether can assist breast can be of any help in this cohort of patients, let's look at this data. So These are the genomic platforms which is available so far: the Oncotype DX 21 gene recurrence score, the MammaPrint 70 gene signature, the EndoPredict 11 gene signature, the Prosigna which is 50 gene signature. So Oncotype DX classify into low, intermediate, high risk. The MammaPrint classify into low and high risk. EndoPredict, they classify into low and high risk. Prosigna, they classify into low, intermediate, high risk. But these all tests, they actually have studied majorly the Caucasian population, the higher age group patients, smaller tumors, and node negative tumors. In all those studies, so Asian population were underrated and underrepresented. So tumor biology definitely play an important role, and tumor biology may differ by the race, by the geographical distribution of those patient population, and which result in the significant disparity in results. This is the data which is showing that the 21 gene recurrence score, that is the Oncotype DX score, that is not predictive for Asian population. So we can see here that there is no improvement in survival by adding chemotherapy in those Oncotype DX high risk group, particularly in Asian population. And again, if you look at the ICMR data, this is also not recommending MammaPrint or Oncotype DX as a routine recommendation for deciding adjuvant chemotherapy in Indian patients, because they are citing that their clinical utility and added value in routine practice is yet unknown, because the data in Indian patients are still limited. So the ICMR is not recommending Oncotype DX or MammaPrint. Now, again, if you look into the tumor biology, there is a gross difference in tumor biology when we are comparing between Asian population versus Western population. If you look into Western breast cancer patients, mostly we find elderly population, it is found among elderly population, the smaller tumors, lesser aggressive biology, node negative disease. So they are having in the favorable risk group type. Whereas if you look at the Asian breast cancer patients, so frequently we find this in younger population, with aggressive disease biology, high tumor burden, and nodal positivity. So definitely Asian breast cancer populations are younger with aggressive disease biology and high tumor burden and node positivity. So definitely our requirement is something like a unique prognostic test that is suitable for our patients, not based on the Western data. So based on this biological data, so this novel proteomic risk prognostication idea was started in 2018, the can-assist breast. So that goes beyond the routinely performed the clinical grade or age or the IHC4 testing. So what additional markers they have incorporated? These are CD44, so which is mainly representing the epithelial mesenchymal transformation, the E-cadherin, N-cadherin, the pan-cadherin, which plays important role in tumor invasion and metastasis, the ABCC4, ABCC11 gene, those play an important role in chemotherapy resistance. So these 4-5 genes are included in this can-assist breast testing. So here they have incorporated the clinical parameters, the machine learning, and the biomarkers. So overall, they have risk stratified based on the cutoff value of 15.5. So they have found the high risk groups was about 30% and the low risk groups was about 70%. So this can assist breast has been validated in 4,000 plus patients from India, USA, Europe, and it has got a high accuracy with 95% negative predictive value compared to Western multi-gene testing. So the patent is granted in India, US, China, Europe, Canada. It has been already published in many peer-reviewed journals. So the inclusion criteria for can-assist breast is particularly in female patients, not in male patients. It included invasive ductal carcinoma, invasive lobular carcinoma, metaplastic carcinoma, mucinous cancer, hormone receptor positive, HER2 negative, clinically T1, T2, T3, N0, and in N1 disease, clinical T1, T2, with any Ki67, any grade, and any age. This can-assist breast study has been validated in 4,000 patients, 22 clinical studies, and it has got a equal accuracy across multiple ethnicities. So different centers from India had participated in this study. You can see here, and one sample report here for the can-assist breast. For one patient, this CAP score came up to be 23.1. So the data, the analysis has shown already that the chance of 5-year probability of distant recurrence in this cohort was, in this patient was 19%, which is quite high. So there is a 19% chance of recurrence at 5 years. So this patient definitely need a adjuvant chemotherapy in addition to hormone therapy. Now, this study has shown that can assist breast. So irrespective of chemoendocrine therapy or endocrine therapy the patient has received, so the high risk group is showing inferior survival compared to the low risk group. Now, irrespective of node positive or node negative cohort, the CAV high risk group has shown inferior survival compared to CAV low risk group. So you can find that in the node negative population, the CAV high risk group was about 20%. In the node positive group, the CAV high risk group was about 50%. So in a node positive early breast cancer, chances of getting CAV high risk is about 50%. In the early breast cancer, chance of getting with node negative, the chance of getting CAV high risk group is about 20%. You can see. Now, if you look the addition of chemotherapy to endocrine therapy, whether giving benefit in the CAV low risk or not, we can find here that the only high risk group by the CAV, they got derived the benefit by adding chemotherapy to endocrine therapy. Whereas in the CAV low risk group, there is no benefit of adding chemotherapy to endocrine therapy. So only CAV high risk groups, they get benefited from adjuvant chemoendocrine therapy. Now, if you look into the clinically low risk group, be it a clinical T1, T2, N0 or low K67 or intermediate K67. So in all these subgroup, in all these cohorts, still there are CAV high risk patients. So even in low clinical risk group patients, we can find CAV high risk patients who really needs the addition of chemotherapy to endocrine therapy. We can find here clinical T1, T2, N0. So about 10 to 12% of patients, about 10% of patients are still CAV high risk. In the low K67, less than 5%, still there are 15% of patients who are CAV high risk. In the K67 intermediate, still there are 25% of patients who are CAV high risk. So definitely, so even if low clinical risk, CAV high risk derives benefit from chemotherapy. So if you look here, the concordance rate between oncotype DX and CAV, the can assist breast, was 83% in the low risk stratification group. Now, this is very important that the 10-year retrospective data, the 10-year data of this can assist breast in the Dutch cohort of TEAM trial. The TEAM trial stands for tamoxifen exemestane adjuvant multinational trial. So the can assist breast was validated on 40 patients. The tumor block was retrieved from the patients in the Netherlands. So those cohorts primarily included postmenopausal, node positive, and those treated with hormone therapy alone. So this is the longest data of 10-year follow-up data. We can find here that the CAV high risk groups, they had a significantly higher risk of distant failure compared to CAV low risk group. We can see here the 4 Kaplan-Meier curve. So irrespective of lymph node positive or lymph node negative, but CAV high risk group had an inferior survival compared to high risk group. If you look at the 10-year follow-up data, in the CAV high risk group, there is a failure rate of almost 30% of more. In the CAV low risk group, after 10 years, the failure chance is about 10 to 12%. Now, this is the multivariate analysis of TEAM trial after the 10-year follow-up. It has shown that the can assist breast risk score was a significant predictor of distant metastasis. We can find the p-value was significant. So can assist breast, the CAV is an independent prognostic factor which affects the distant metastasis free survival. Now, this is the consensus guideline in the SARC region. It is recommended that the can assist breast and Oncotype DX are the can assist breast is recommended having the substantial documented evidence. The only currently available predictive test for hormone receptor positive or to negative early breast cancer that has been validated in Indian patients is the can assist breast. And this can assist breast also predictive test that predicts risk of recurrence across ethnic backgrounds and geographies and is affordable in low middle income countries. And in this can assist breast studies, so most of the population, about 80% of population, they were postmenopausal, they had a node negative disease, and they were low grade tumors. Now, if you look at the CAV prognostication in the estrogen receptor low positive or high positive tumors, we can find that they have classified into year 1 to 10%, year 11 to 20%, or more than 20%. So what they have found that the CAV high risk was significantly higher when the patient is having ER low positive tumor, and in the ER low positive tumor, that actually CAV high risk proportion was very, very high. And particularly when we see that in the node positive who are ER low positive, in the node positive ER 1 to 20%, the proportion of CAV high risk is very, very high, almost about 50%. So their addition of chemotherapy is very, very essential, and we have to escalate the treatment in this cohort when a early breast cancer, hormone receptor positive or HER2 negative, but ER is 1 to 20%. There is a high chance that CAV high risk of the chance of getting CAV high risk is about 50%. So definitely we have to look into this cohort. This is the real world data. They have looked into this clinical and the CAV risk model. They have found that when there is a clinical intermediate risk, that is if there is a Ki-67 of 6 to 29%, still there is a chance that 50% of those intermediate clinical risk will be having CAV high risk. In case of in those studies, they have found about 2/3 of patients had a CAV high risk and 1/3 of patients had a CAV low risk patients. So in conclusion, CAV can guide physicians in deciding chemotherapy treatment planning in the adjuvant setting in early breast cancer. So CAV low risk group can be spared from adding chemotherapy to endocrine therapy. These are the data presented at ESMO Congress at Barcelona 2024, showing that the CAV low risk is about 72% in their study. In the Istanbul 2024, they have found the CAV low risk is about 69%. In the SABC symposium, they have reported that the CAV low risk is about 66%. So on an average, the CAV low risk constitute about 2/3 of patients. This is the data from Mahatma Gandhi Cancer Center from Visakhapatnam. It was discussed in ESMO breast cancer conclave. They have reported that CAV low risk was about 74% in their study. So this is another data from, it was discussed in the Asia Pacific Breast Cancer Summit. So it is also shown that the CAV low risk category is about 70%. So the CAV has a reach of worldwide. So in India, Turkey, UAE, Saudi Arabia, Sri Lanka, Bangladesh, Iran. So it has got a wide zone of coverage, and it has shown multi-country validation. So affordable, definitely it is affordable innovation and quality driven. So fastest turnaround time, the TAT is about 7 to 8 days, and mostly it has been validated on Asian younger population also, which was a limitation in the Western studies. These are different international publications. So to summarize, the CAV proteomics and AI-based prognostic test has been validated on Asian population, and it is performed in the central lab with reporting done in TAT of 8 days. So it is classified into CAV high risk and CAV low risk. CAV high risk has shown to add survival benefit by adding chemotherapy, whereas CAV low risk can be spared from adding chemotherapy. There is a more than 83% concordance between CAV low risk and Oncotype DX low risk category. And after 5-year follow-up, the negative predictive value of this CAV test is more than 95%. So 10-year follow-up data is there from the team trial, which has shown that the CAV high risk has a high risk of recurrence of about more than 30%, whereas CAV low risk having a recurrence of about 10%. So definitely the 10-year follow-up data is there for this CAV test. And it can also risk stratify the intermediate Ki-67 because it has been shown that even 50% can have a CAV high risk. So definitely CAV is a solution for our patients with it's a solution to our problem in our group of patients, where this is a very cost effective and can be used to select patients for adjuvant chemotherapy. So thank you everyone, and any suggestions, feedback or any questions, so I'll be happy to take.
Thank you so much, Dr. Sri Gopal.
Yeah.
So now I would like to invite Dr. Saurav Kumar Mishra. He's an associate professor, head of department, medical oncology, AIMS Bhubaneswar, to take this webinar forward with his talk. Welcome, sir.
Good evening, everyone. So can I share my slide decks? Yeah, am I audible?
Yes,
Yes,
sir.
sir. Yes, sir.
So can I share my slide deck?
Yes, sure, sir.
Okay. So are my slides visible?
Yes, sir. Yes, sir.
Yeah. Can you just give me 1 minute? Yeah. So thank you, Sri Gopal. So
Good evening, sir. Yes, thank you.
good evening. And I would like to congratulate you first for initiating this lovely meeting on advances. And we have so many eminent speakers from across India. So my talk today is management of brain metastasis in HER2 positive breast cancer. So I will be predominantly focusing on the brain metastasis. So I would be discussing on the overview of brain metastasis, what is the incidence, then the management of brain metastasis. Although there are local therapies and systemic therapies, I will mainly focus on the systemic therapies and the data for these systemic therapies. So you see here that the incidence of brain metastasis in HER2 positive breast cancer is around 25 to 50%. 1 in 3 patients will develop a brain metastasis during their natural history. And patients who have brain metastasis traditionally have been refractory to most of the systemic therapies which we had, and the median survival is actually very low in them. And the incidence of brain metastasis is going to increase in the future because more and more patients are going to survive longer because of the systemic therapy. So once you have a brain metastasis, then the treatment paradigm depends on multiple factors. Patient fitness is one of them, but the most common and most useful parameter taken by the oncologists is usually something favorable prognostic factors and unfavorable prognostic factors, and something which is survival if it is less than 3 months. So someone who is expected survival is less than 3 months, preferably to go for a best supportive care. However, if you have a favorable prognostic factor, like you have around 1 to 10 lesions, and the combined volume of these lesions is less than 15 ml, they have a very well controlled extracranial disease, and they are absolutely fit patient and a good survival expected, then such patients would go for a surgery followed by stereotactic radiosurgery or stereotactic radiotherapy, and then systemic therapy should be followed after you go for some of these local therapies. So these are basically for the very symptomatic brain metastasis. However, if a patient has an unfavorable prognostic factor, that means there are multiple metastases, more than 10, large volume, and they are uncontrolled CNS disease. In such patient, preferably local therapy would be whole brain radiotherapy, and after that we go for a systemic therapy, which is the most appropriate. So with that understanding that we have to go for a local therapy based on the prognostic factors, we see now what are the most common systemic therapy for these diseases. So in the front line, as you know, irrespective of brain metastasis, the current recommendations are to use a dual anti-HER2 blockade, pertuzumab, trastuzumab with a taxane. And at progression, we would go for a trastuzumab deruxtecan, and third line would be tucatinib, trastuzumab, capecitabine, or adotrastuzumab, emtansine, or TDF1. And then subsequently, there could be combinations of trastuzumab with other chemotherapies, lapatinib and capecitabine. This is also reflected in the ESMO guidelines. You can see those patients who are newly diagnosed with HER2 positive metastatic breast cancer, irrespective of brain metastasis, the systemic therapy is taxanes with dual anti-HER2 blockade. What are the current recommendations on systemic therapy? Will predominantly focus on patients who are having brain metastasis rather than the systemic disease. So straight away, I go ahead with the most effective currently available therapy, and that is trastuzumab deruxtecan. Now, this is a pooled analysis of all the Destiny trials. We had the Destiny Breast 01, which was a single-arm study. It included patients who were asymptomatic and previously locally treated brain metastasis. That is what we called as stable brain metastasis. Then we had the Destiny Breast 02 trial, where they compared TDXD with the standard of with the physician's choice of either trastuzumab capecitabine or lapatinib capecitabine, and it included patients with both untreated and treated metastasis. And then we have the Destiny Breast 03 trial, which was a comparison of trastuzumab deruxtecan versus TDM1. Again, it included asymptomatic and previously treated and untreated metastasis. So this retrospective pooled analysis, it compared the TDXD brain metastasis pool comprising of 148 patients compared with brain metastasis in the comparator pool, that was the number of patients were around 83 patients. So what you can see here is that on the left-hand side panel, response rates with TDXD in the brain metastasis is around 45% in those subset of patients that included treated stable brain metastasis or untreated and active brain metastasis. In either of the subset of patients, you get a response rate of 45%. And if you see the comparator brain metastasis pool, you can see if they are treated metastasis, the responses are around 27%, but if they are untreated, the responses are absolutely poor. This clearly shows that TDXD has a good CNS activity in the patients across multiple lines of treatment, previously treated with TDM1 or previously treated with other systemic therapies. And if you see here again, this is an exploratory CNS progression-free survival. You can see here the median PFS in the subset of patients with treated metastasis with TDXD was 12.3 and with the comparator 8.7. But what was really interesting was that in those patients who had untreated or active brain metastasis, in these patients, you can see the activity of TDXD 18.5 months was the median CNS progression-free survival, whereas the comparator arm did very poorly. So that means that even in patients who are having untreated or active brain metastasis, without going for a local therapy, you can get a very good response and you can get a very good progression-free survival with the TDXD. So this was something which we did with the pooled analysis with the multiple Destiny. Now there was a prospective study, the Destiny Breast 1-2 study. And in this was a phase 3b4 multi-center single-arm open-label study with TDXD in previously treated HER2-positive metastatic breast cancer with or without brain metastasis. They had included stable brain metastasis, or they had also included active brain metastasis, meaning untreated or previously treated but progressing. But they do not require immediate local therapy. That is the meaning of the active brain metastasis. And they had excluded the leptomeningeal disease. Now, that is again a very bad subset of patient, leptomeningeal disease. So this Destiny Breast 12 was a prospective study, and it tried to compare the outcome between patients with baseline brain metastasis who were treated with TDXD and had progressed on less than equal to 2 prior lines of systemic therapy, but did not receive tucatinib. And you can see here that the progression-free survival, this is not the CNS progression-free survival, this is the overall progression-free survival. With this brain metastasis, with a data maturity of 42% was 17 months. Now that's really good. I mean, with brain metastasis, patients with active as well as stable metastasis doing more than 1.5 years median progression-free survival. You can see there activity was seen with both active brain metastasis, whether they were previously treated or previously untreated, as well as stable brain metastasis. Now, CNS progression-free survival, you can see at 12 months, or that is 1 year, 60% of the patients or 59% of the patient did not have any CNS progression, showing that they are very well controlled metastasis, and which was very similar between the stable brain metastasis or active brain metastasis, that is the 12-month CNS progression-free survival. This is the CNS response rates in those patients who had measurable disease. And in that, you can see the overall response rate at the CNS was 72%, and with stable brain metastasis, it was 79%. With active brain metastasis, 62%. The best responses were with the untreated active brain metastasis, in which the response rates were almost 80%. Now, that's really good data for patients who are having brain metastasis, showing the very good activity of this drug in the central nervous system, especially in the untreated brain metastasis population. This is the overall survival in this subset of patients, which was very similar between patients who had baseline brain metastasis, 12-month 90%, or no baseline brain metastasis, which was equally. So even if you had a brain metastasis, traditionally we see the OS is low, much low compared to those who have no baseline brain metastasis. But in this study, we can see with TDXD, the responses are and survival is very good. The safety summary, if you see, so there are some toxicities which are not new compared to which have been previously found in other studies, or there is no difference as such between patients who are having baseline metastasis and no baseline metastasis. Interstitial lung disease, grade 5, 2.3% in patients with brain metastasis, 1.2% in patients without brain metastasis. So conclusion of this study was that in this prospective phase 3b/4 study, TDXD exhibited substantial and durable overall and intracranial activity in clinical activity in a large patient cohort, and the CNS response rates was overall 72%, with stable mets 80% almost, with active mets 62%, and untreated mets also brain metastasis, very good response, 12-month overall survival of 90%. Now, with this data that TDXD has such a superior activity, let us go ahead with the previous data. The only randomized study with brain metastasis has been with the HER2 trial, that is tucatinib plus TDM1 versus placebo plus TDM1 in patients who had active or stable brain metastasis. And you can see here in the subset of patients who had brain metastasis, the combination of TDM1 plus tucatinib results a response rates of 43%, and similarly only TDM1 so that the presence of brain metastasis, you can see almost active brain metastasis, and in the equal number of patients are there, and in that you can see that the median progression-free survival was 9.5 months with TDM1 plus tucatinib, significantly improved median progression-free survival versus TDM1. The secondary endpoints were progression-free survival with brain metastasis, 7.8 months. We will see the comparison, how TDXD fares in comparison to this regimen. The OS data was immature. So this shows the activity of TDM1 plus HER2 plus tucatinib. But of course, this regimen has a lot of toxicities, in that more frequent hepatic events in this combination. So this is the cross-trial comparison. You can see here, just try to see out of all the studies which were mentioned here, you see with the HER2 with the tucatinib and trastuzumab plus capecitabine regimen, the baseline, the patients included were both stable as well as active brain metastasis. Progression-free survival was 7.8 months. Overall survival was 21.9 months, and CNS progression-free survival was around 10 months. If you compare this data, so CNS progression-free, so within 10 months, almost 50% of the patients had progression. But if you see the Destiny Breast 1-2 study, which specifically included brain metastasis in a prospective manner, you can see at 12 months, almost 60% of the patients do not have any CNS progression. The median survival at 12 months was almost 90 months. The progression-free survival was very good. That is the overall progression-free survival, 17.3 months. Similarly, if you see other Destiny trials, you can see that the CNS progression-free survival has been really much better compared to the tucatinib plus trastuzumab plus capecitabine. 18 months here, not reached, 15 months, 16 months. So all of these studies, they show of the superior activity of TDXD in compared to tucatinib in terms of brain metastasis control. So what about the active brain metastasis? So is there data to say that active brain metastasis, what is the best regimen? So HER2 study, CNS overall response rate 47% in those patients who had this active brain metastasis. And in the destiny, you can see in the untreated patient, as I said, the response rates were 83%, treated and progressing 50%. So the untreated patients saw a very good response with the destiny regimen, and the CNS response rates are definitely better in the TDXD arm compared to the tucatinib arm. Now, these are previous data. So with that, we saw about the two most active agents, that is TDXD and then tucatinib plus capecitabine plus trastuzumab. The CNS response rates with TDM1 in the Camellia trial was 21.4%. With lapatinib only, the response rates are very low, 6%. If lapatinib plus capecitabine, response rates are around 20%. And one study with the landscape trial, single arm, small number of patients, 45 only, somehow lapatinib plus capecitabine showed a good CNS response of 66%. So overall, we can say that most of the patients which we have seen in these studies have responded very well in the CNS as well as with extracranial disease with TDXD rather than other agents. What about leptomeningeal disease? Last slide about this. So as you know, the leptomeningeal disease are excluded in most of the studies. This is the DEBRA trial in which they included specifically the cohort 5, the leptomeningeal disease patients with HER2 positivity, and they gave them trastuzumab deruxtecan. And you can see here the median overall survival was 13.3 months with leptomeningeal disease. The very good thing was that 71.4% of the patients achieved a prolonged stabilization of their leptomeningeal disease more than equal to 24 weeks with the trastuzumab deruxtecan. This really shows the encouraging data of trastuzumab deruxtecan, not only with active or stable brain metastasis, but also with leptomeningeal disease. So to conclude, integrated therapeutic approaches to be discussed at a dedicated brain metastasis board, at a disease-specific tumor board. Always consider local treatment, then use standard systemic treatment. If local interventions are not indicated, use the best medical treatment available. TDXD better than tucatinib, trastuzumab, capecitabine, better than TDM1, better than trastuzumab plus other therapies. So thank you once again, Sri Gopal and the team, and AstraZeneca for this opportunity. Thank you.
Thank you, Dr. Saurav. So for the next session, we have with us Dr. Tamuji Chaudhary. He's a senior consultant and head of department medical oncology at Meherbai Tata Memorial Hospital, Jamshedpur. Welcome, sir.
Good evening. Kindly share the slide deck from your end.
Sure, sir. Just a second.
Perfect. Visible. Hope I am audible to all of you. So good evening, and thanks to organizers for this opportunity. Thanks to Dr. Sri Gopal for this kind invitation. So for next 20 minutes, we'll focus on the muscle invasive bladder cancer management, and particularly the non-metastatic setting. So mainly we'll focus on stage 2, stage 3, and stage 3B disease. So as we are all aware that the standard of care, at least few months earlier, the standard of care of muscle invasive stage 2, stage 3, and stage 3B urinary bladder cancer was platinum-based neoadjuvant chemotherapy followed by radical intent surgery, particularly for patients with muscle invasive bladder cancer and who are eligible to receive platinum-based neoadjuvant chemotherapy or perioperative sort of chemotherapy. But the issue is, if we focus on anything which is beyond pathologically T3 disease or N+ disease, the relapse risk is at near about 40 to 50% at 3 years. So that means after 3 years of initial standard of care treatment, 5 out of 10 of our patients will have a recurrence of the disease, and once recurred, these are broadly incurable. So the baseline is that we need better systemic therapy options. So how to improve the therapeutic options? One of the option is to add immunotherapy drugs, which is available in our country for almost last 1 decade. And so we are all aware of the pure adjuvant trials. We are also going to discuss those. But the problem of pure adjuvant trials is they have not consistently shows the OS benefit. So probably using a neoadjuvant and post-op adjuvant, so perioperative sort of use of immunotherapy is probably the way forward, at least as per the data available from other solid malignancies, including NSCLCs and CS stomach. So that will be the main point of discussion for today's topic on muscle invasive bladder cancer. Next slide. So I'll just quickly wrap up the initial slides. Next slide. Slides are not moving. Yeah. So this is basically 9th most common diagnosed cancer worldwide and 13th most common cause of cancer-related death. What is visible is that once we progress the disease stage from a localized to regional, there is a significant drastic drop of 5-year overall survival. Next slide. And so broadly, these are classified into non-muscle invasive and muscle invasive. So anything which spread beyond the connective tissue and detrusor muscle becomes T2 or muscle invasive disease. So overall, stage 2, stage 3, and stage 3B disease are localized or loco-regional disease with or without nodal involvement in the true pelvis, as per the current AJCC staging. Next. So the mainstay of treatment, as we have discussed, next slide. Mainstay of treatment is cisplatin-based neoadjuvant chemotherapy followed by radical cystectomy and pelvic lymph node dissection, and particularly patients who are not willing to undergo a radical intent surgery, not fit for platinum-based neoadjuvant chemotherapy, or medically unfit to undergo surgery. Particularly for those group of patients, we usually select a bladder preservation protocol, which is predominantly chemoradiation or radiotherapy if the patient is unfit to receive even non-platinum agents. Next slide. So I believe this is already discussed. So standard of care is platinum-based neoadjuvant chemotherapy followed by radical intent surgery, which is radical cystectomy plus bilateral pelvic lymph node dissection. And when you talk about systemic therapy addition, neoadjuvant chemotherapy, which is platinum-based, is preferred over pure adjuvant trials. The reasons we are going to discuss in subsequent slides, particularly for patients who are not candidates for radical intent surgery or not willing to take surgical risk or not fit for neoadjuvant platinum-based chemotherapy, bladder preservation protocol is usually applied. Next slide. So yeah, this already been discussed. So radiotherapy and radiotherapy may be used for selected muscle invasive bladder cancer patients, like not suitable for cisplatin-based neoadjuvant chemotherapy, ineligible for radical intent surgery, do not want to undergo cystectomy, and as also as a palliative approach for advanced disease. Next slide. Now, when you talk about non-surgical treatment options, next slide. So the two options are there. One is the radiotherapy and the second one is cisplatin or non-platinum based chemoradiation. Now, when you compare the survival and toxicity data, there is clear-cut survival advantage of chemoradiation for bladder preservation protocol over and above radiotherapy alone. Next. And in terms of survival, the platinum-based versus non-platinum-based chemoradiation is almost equal, but there are toxicity implications which are different for platinum versus non-platinum based. Non-platinum based is supposedly to be less toxic, but at the same time, the survival gain is not there. Next slide. So there are a lot of advantages and disadvantages. Next slide. Yeah, so this is basically regarding the advantages and disadvantages of neoadjuvant and adjuvant chemotherapy. So as we have discussed, there is a very robust data which suggests that cisplatin-based neoadjuvant chemotherapy will provide at least 5 to 8% of 5-year overall survival gain over and above the radical intent surgery alone. That robustness of evidence of survival gain in the similar magnitude is not there for a pure adjuvant chemotherapy trials. Although the trial suggested that there is OS benefit, but majorly these are DFS benefit. Next is with neoadjuvant chemotherapy, we can have an idea regarding the biology of the disease, whether these are responsive, chemo-responsive disease or not, and further subsequent therapies can be decided based on that. That advantage is not there for adjuvant. One major problem of adjuvant is after radical intent surgery, which is a major visceral resection. Sometimes there are issues with tolerance of full dose platinum-based chemotherapy. Next slide. So among platinum-based chemotherapy, there are two most commonly used regimens as of now. One is dose-dense MVAC, another one is gemcitabine cisplatin. Next slide. And there is a retrospective evidence of various platinum-based and non-platinum-based chemotherapy regimens. Though particularly if we focus on the gemcitabine cisplatin versus MVAC regimen, which is full dose 4-weekly MVAC regimen. Absolutely, there is no difference in the survival parameters, but there are certain toxicity implications which suggested that full dose 4-weekly MVAC without any myeloid growth factor support is actually more toxic than gemcitabine cisplatin. Next slide. Now, there are ample amount of evidence that bladder tumors are actually immunologically hot tumors, particularly if you focus on the BCG or Bacilli calmette urine data for intravesical immunotherapy in the non-muscle invasive bladder cancer, which provides the proof of principle. Moreover, there is a high rate of tumor mutation burden in the bladder cancer, and so it suggests that the environment is suitable for immunotherapy. Next slide. Now, for dose-dense MVAC versus MVAC, again, the tolerance and toxicity patterns are quite favorable for dose-dense MVAC, particularly if you use myeloid growth factor support. Next slide. Now, what is the ideal platinum-based chemotherapy regimen, particularly for perioperative or neoadjuvant setting? All these trials are before the incorporation of immunotherapy drugs in bladder cancer. So when we compare this very landmark trial, the phase 3 VESPA trial, which compared between dose-dense MVAC and gemcitabine cisplatin, so which suggested, next slide, that there is a significant PFS benefit favorable for the dose-dense MVAC regimen in comparison to the gemcitabine cisplatin regimen. All the toxicity parameters are totally different. Next slide. Yeah, so and also there is some trend towards the 3-year or 5-year overall survival gain favoring the dose-dense MVAC arm. Next slide. So now this is again a very important aspect, particularly as we are practicing, most of us practice in the Eastern India, where most of the patients present with a very advanced stage of disease with some sort of bladder outlet obstruction, which leads to the impaired renal function. So moreover, 40 to 50% of our patients in real world setting are actually unfit to receive full dose platinum-based neoadjuvant chemotherapy because of the poor performance status or comorbidities or poor renal function or cardiac function. So the issue is there is actually no standard of care for those group of patients which are supposedly have a bad disease biology or bad outcome because we can't offer them the optimal therapies. And this is probably the need of the hour as of today. Next slide. So adjuvant versus neoadjuvant, there are certain advantages of neoadjuvant and certain advantages of adjuvant. But as of now, because of the robustness of the overall survival gain, which is visible in the range of 5 to 8% purely with neoadjuvant chemotherapy, we all prefer to give neoadjuvant chemotherapy, particularly in cisplatin eligible patients. Next slide. Now, as we have discussed that in spite of giving a full dose optimal standard of care, which is either 6 cycle of dose-dense MVAC or 4 cycle of cisplatin gemcitabine, followed by radical intent surgery, in spite of giving that for a stage 2, stage 3 and stage 3B patient, 50% of our patients will have a disease recurrence at 3 years. So that means with the standard of care, still there is a lot of scope for improvement. So how to improve those outcomes of survival? One option is to add pure adjuvant immunotherapy drug or some sort of different chemotherapy drugs. So as of now, there are 3 landmark trials of adjuvant immunotherapy, but unfortunately, two of those trials have not shown any significant benefit at the primary endpoint. So one of those failed data is from IMvigor 010, which is a all-comer population. There is certain high-risk criteria used to select patient in all these 3 adjuvant immunotherapy trials, which I will discuss in subsequent slides. So moreover, the take home is that pure adjuvant atezolizumab for high-risk muscle-invasive bladder cancer with or without neoadjuvant chemotherapy post-radical intent surgery is actually a failed data. It's not approved as of now. Next slide. The next is basically an IMvigor 011 study. It's almost a similar sort of design, but again, there is an enrichment of the high-risk criteria by using ctDNA positive plasma sample after radical intent surgery. Again, the patients are eligible for cisplatin-based neoadjuvant chemotherapy. Most of the patients receive cisplatin-based neoadjuvant chemotherapy, and there is certain high-risk criteria to be selected for patients who underwent upfront surgery versus post-neoadjuvant chemotherapy. So overall, again, 2:1 randomization between atezo for 1 year versus placebo. But again, there is absolutely no difference in terms of the primary endpoint, which was the DFS at 3 years. Next slide. So this is probably the most important adjuvant immunotherapy trial, which is the CheckMate 274 study. Again, 1:1 randomization after neoadjuvant chemotherapy or after radical intent surgery into 1 year of adjuvant nivo versus placebo. Primary endpoint was DFS in the ITT population and DFS in the PDL1 enriched population. Now, again, these are all high-risk patients after radical intent surgery. Now, what we can see is that when we talk about both in the ITT and PDL1 enriched population, next slide. when you talk about both the ITT and PDL1 enriched population, there is a significant benefit favoring the nivolumab arm of the primary endpoint, which is the DFS at 3 years majorly and median DFS. Next slide. So this particular indication, nivolumab already got the FDA and EMA approval. Next is the Pembro data, which is ambassador study. So again, the high risk criteria used for a patient selection of all these three trials, Atezo, Nivo, and Pembro trial, are very much similar. These are post neoadjuvant chemotherapy more than equal to YPT2 disease or YN plus disease or margin positive, or cisplatin eligible and refusing, and that means upfront surgical resection done, and these are pathologically T3 disease and or more than PN plus disease or margin positive disease. So almost all these three trials use the similar sort of high risk criteria. Again, a 1:1 randomization between 1 year of adjuvant Pembro versus observation. Primary endpoint were two actually. One is the disease-free survival, second one is the overall survival. Next slide. So as per the long-term follow-up data, what is suggested is that one of the primary endpoint is significantly favoring the Pembro arm, but another one, the overall survival, is not significantly better. Next. And even the long-term follow-up suggested that OS benefit is not significant, and that resulted in, there is, as of now, the Pembro is means it is not approved by NCCN, not approved by EMA. So as of now, only Nivo is approved in the PN neoadjuvant setting, both by NCCN and EMA. NCCN approval is irrespective of the PDL1 status, and EMA approval is more than 1% enriched population for Nivo. Next slide. So this we have all discussed, the 50% relapse risk at 3 to 5 years. Overall survival gain with cisplatin-based neoadjuvant or perioperative chemotherapy is only 5 to 8%, which is very modest, and there is a lot of scope for improvement. And there is a conflicting evidence and no robust evidence of overall survival gain with pure adjuvant IO trials. Only data which is positive is nivolumab, which is approved both by NCCN and EMA, but for a different PDL1 subgroup as per the NCCN and EMA. Next slide. So this, so as of now, what we have discussed is actually formed the basis or biological rationale for designing a perioperative sort of trial for immunotherapy addition over and above the cisplatin-based neoadjuvant chemotherapy in muscle-invasive bladder cancer, including stage 2, stage 3, and stage 3B patients. So this is the landmark trial. We are all aware of the Niagara study. So it's basically a global open-label phase 3 randomized control trial of neoadjuvant durva plus platinum-based chemotherapy, followed by radical intent surgery, which is radical cystectomy, bilateral pelvic floor dissection, and followed by adjuvant durvalumab for almost 1 year total duration for an MIBC patients. Next slide. So adult patients more than 18 years of age, which are cisplatin eligible, clinically more than T2 up to T4A or N0 or N plus M0, either classic urothelial carcinoma or urothelial carcinoma with any differentiation, which can be an squamous or adeno differentiation not included, evaluated and confirmed for radical intent surgery, which is radical cystectomy, and creatinine clearance has to be at least more than 40 ml per minute. The experimental arm was durvalumab every 3 weekly 1500 mg along with gemcitabine cisplatin for 4 cycles, and followed by radical intent surgery, followed by adjuvant durvalumab for 8 cycles, but that time that was given, the same dose has been given every 4 weekly schedule. The standard comparator arm was gemcitabine cisplatin based 4 cycle neoadjuvant chemotherapy, followed by radical intent surgery and then observation. Dual primary endpoints were event-free survival and pathological CR. Now, if we remember the primary endpoints of all these perioperative studies of operable NSCLCs, as well as the Matterhorn data, which is the CS stomach operable, it suggested that the primary endpoints and secondary endpoints are very much identical for all these perioperative chemoimmunotherapy trials for solid tumors. So dual primary endpoints, again, EFS and PathCR, secondary endpoints, overall survival and safety parameters. Next slide. Now, this is the basic baseline demographic parameters, quite comparable between the experimental and the standard arm. Renal function, if we particularly focus, then borderline renal function, that means creatinine clearance 40 to 60, only 20% patient enroll in both arms. T2N0, which is supposed to be very early stage muscle-invasive bladder cancer, again enrolled only 40% as a study predefined criteria in both arms. PDL1 enriched population was near about 73% in both arms. Here, the definition of cutoff is more than equal to 25% TC by IC criteria based on the Pentana platform, means results of the PDL1 IC. Next slide. So both the dual primary endpoints, the EFS and overall survival, there is a very significant benefit, which is hazard ratio is 0.68 for EFS, hazard ratio is 0.75 for OS, favoring the durvalumab arm. Next slide. PAT-CR rate is again, as per the central review, there is almost 10% incremental benefit favoring the durvalumab arm, 27 versus 37%. Next slide. Now, if we focus on whether the event-free survival is favorable for PCR versus not PCR, what we can see is that this Kaplan-Meier is very much similar again to just like the Pembro study of triple-negative breast cancer, the Keynote 522 study. The similar sort of Kaplan-Meier curves were visible in this trial also, in the Niagara study also. So if we compare the PAT-CR rate and again Durva versus the observation control arm, and again the non-PAT-CR rate, what is visible that there is, in spite of patients achieved PAT-CR or did not achieve PAT-CR, there is a statistically significant benefit favoring the Durva arm over and above the control arm. So that simply means that there is always some advantage of giving the adjuvant 8 doses of durvalumab in those population of patients in spite of achieving the PAT-CR, at least from this Kaplan-Meier curve. Next slide. And the similar sort of curve is applicable for overall survival also. So in spite of achieving a PAT-CR, if you continue durvalumab for adjuvant setting for another 8 doses, there is still a significant benefit which can be achieved with continuation of the standard experimental arm as per this trial. Next slide. Again, other secondary endpoints like DFS again favorable for the durvalumab arm. Next slide. And this is again very important that when we talk about the borderline renal function patients, particularly creatinine clearance 40 to 60, whether the similar sort of benefit is there or not, that is again very important. So as a trial inclusion criteria, these borderline renal function patients were enrolled only up to 20% patient in each arm. When we see the PAT-CR rate and the EFS, which is the dual primary endpoint for the ITT population, when we see for this population, this subgroup of borderline renal function, again, the significant benefit is pretty much well maintained, similar to the ITT population. Next slide. Now, this is basically the toxicity tabulation. What is visible is that the treatment-related grade 3-4 toxicities happened almost similar to the durvalumab comparator arm, which is near about 41% in both arms. And when you focus on the immune-mediated toxicities, again, overall, these are 20% versus 3%, durvalumab versus comparator arm, which is quite expected. Next slide. So this is just a summary of pure adjuvant immunotherapy trials. We have all discussed all the points regarding these 3 trials. The CheckMate 274 is the only positive study for both the dual primary endpoints of 1 year of adjuvant nivolumab in high-risk patients after with or without cisplatin-based neoadjuvant chemotherapy after radical intent surgery. And but the ambassador study of Pembro and IMvigor 010 and 011, both are for pure means adjuvant atezolizumab after radical intent surgery. These 2 data are failed data in terms of non-significant improvement of the primary endpoint. Next slide. So if we focus on all the current international guidelines, be it European Society guidelines, European Andrology Union guidelines, and NCCN guidelines, there is a category 1 recommendation for gemcitabine cisplatin plus durvalumab, followed by radical intent surgery, followed by adjuvant durvalumab, just like the Niagara protocol as a category 1 recommendation for muscle-invasive bladder cancer, for stage 2, stage 3, and stage 3B disease. And when you talk about the adjuvant setting, the same thing is applicable. Next slide. So for T2N0 disease, the similar sort of regimen is mentioned in the NCCN as a category 1 recommendation, particularly if that has not been offered as a neoadjuvant chemoimmunotherapy, then there is always an option of addition of adjuvant immunotherapy, particularly nivolumab, after chemotherapy and after surgery. Next. Now, when you talk about anything beyond T2N0, that means either, next slide. Anything beyond T2N0, that means either T3, T4 disease or N+ disease. Again, this becomes a category 1 recommendation. So durvalumab and cisplatin gemcitabine-based neoadjuvant chemotherapy for 4 cycles, followed by radical intent surgery, followed by 8 cycles of adjuvant durvalumab is a category 1 recommendation for these muscle-invasive bladder cancers. Next slide. So this is in summary and going to be my last slide for today's presentation. So Niagara demonstrated a statistically significant and clinically meaningful improvement in event-free survival and overall survival, which are the significant primary and secondary endpoints for this global landmark phase 3 trial. Event-free survival hazard ratio is 0.68. Overall survival hazard ratio is 0.75. This is as per 24 months landmark point analysis, and probably these hazard ratios will improve further with longer follow-up, at least what is evident from the Kaplan-Meier tail of the Kaplan-Meier curves. The next is perioperative durvalumab in the radical cystectomy population improved the PAT-CR rate almost 10% absolute increment in comparison to the comparator arm, reduced risk of recurrence or death after radical intent surgery by almost 1 out of 3 patients, showed DFS benefit across pre-specified subgroups and in PATH-CR and non-PATH-CR subgroups. So this is again a very important statement. Patients with borderline renal function showed improvement in PATH-CR and EFS, with a similar magnitude like the whole ITT population. So all these additional analysis and these additional analysis from the Niagara provide further support for perioperative durvalumab plus neoadjuvant cisplatin-based chemotherapy as a new treatment option and new standard of care for patients who are eligible to undergo radical intent surgery and eligible to receive full dose cisplatin-based neoadjuvant chemotherapy. So thanks again for this opportunity to the organizers, and back to the organizers. If any question, I'd be happy to answer. Otherwise, I'll stop here.
Thank you, Dr. Tamojit, for this amazing presentation. So now we enter into a very exciting segment, that is a panel discussion, which will be moderated by Dr. Chandrakant MV. He's a consultant medical oncology at Narayana Super Speciality Hospital, Kolkata. I would like to request Dr. Chandrakant to invite the panelists for the discussion and take this forward. Welcome, sir.
Thank you, Dr. Sri Gopal, for this wonderful opportunity. And it was a wonderful talk by Dr. Tamojit just now. So let me invite panelists, Dr. Jogmaya Patnaik, Dr. Nihanti, Dr. Pradeep Kumar Mondal, and Dr. Sushmita Sadhku. Okay, I think we have all the panelists. Let me share the screen. One second. So I think the slides are visible and it is on full screen right now.
Yes, sir.
Right. Okay. So it's a panel discussion from 15 to 25 minutes. That's what we have. So I will just take you through the slides. How to position ribociclib in the advanced breast cancer treatment. So I'll start from Dr. Jogmaya and I'll go to Dr. Sushmita in the same order, and I'll be taking the questions in the same order. Right. So when we see any advanced breast cancer, most important endpoints are overall survival and quality of life. So in any metastatic disease, these are the two important endpoints: how long you live and how well you live. And these are the guidelines. Unless and until you have a visceral crisis or an imminent organ failure, you would give an endocrine therapy plus CDK4/6 inhibitor. And if you look into the overall survival, clearly in the first line in the first line space, clearly a CDK4 with an aromatase inhibitor endocrine therapy, only ribociclib has shown a statistically significant overall survival benefit. You can see clearly palbociclib in Paloma 2 and abemaciclib in Monarch 3 failed to meet the statistical requirements of overall survival. So this is what I was saying: live long and live well. Progression-free survival is a surrogate. At times it may be flawed. So this is what PFS is, not appropriate, may not be always surrogate. So PFS is seldom a surrogate, and it depends on multiple factors like timing of assessment, measurement error, informative censoring, and so on. To date, ribociclib plus CDK4 inhibitor is the only CDK4 inhibitor that has shown overall survival benefit. Right. So let me start with Dr. Jogmaya. Dr. Jogmaya, we can take this question. Based on the evidence, what are your thoughts of PFS being a surrogate for overall survival? Would you consider that PFS always would translate to OS, especially in first line advanced breast cancer setting?
Good evening, everyone. Good evening, Dr. Chandrakant. So my thoughts is that in case of metastatic disease, overall survival is the gold standard for a primary endpoint, to be a primary endpoint. PFS is important just to know how quickly the drug is acting, and just to have an overall idea that roughly how long the drug is acting. Sometimes we may continue the drug even after progression. So therefore, PFS always is not a surrogate, because sometimes we have a PFS 1 and we also have a PFS 2. That means a second line treatment may be also a good treatment option. So it doesn't mean that in first line treatment option, the PFS, whatever we get, that will translate always or decide always the overall survival. So overall survival is just the endpoint is very clear, that death. There is no other ambiguity. So it is more non-ambiguous and it's regarded as the gold standard. And in first line metastatic setting, for any drug to be clinically useful or meaningful, overall survival should be the surrogate, the endpoint rather than a PFS.
Right. Great thoughts. I think very clear thoughts from Dr. Jogmaya. Yes. So people, also like if you hear Ian Tannock saying about PFS, so he says PFS is a planned flawed study or a profit for sponsor study. So this is how they mock PFS endpoint. As you said, PFS may not be always a surrogate for overall survival. Overall survival is a gold standard endpoint for any clinical trial, especially in the advanced setting. Right, let's quickly go through the mechanism of actions. CDK4, CDK6, both are important. You need to have a predominant CDK4 activity than CDK6. And from this, what you would understand is the off-target action. So if you look into ribo, it's the red one is only in the CDK4/6 space. And if you look into Abima, you can see the red dots all around. It's on TKL, STE, CK1, AGC. So a lot of off-target effects, and therefore you would see fatigue and diarrhea as the side effects of abemaciclib. So this is the selectivity of ribo and palbociclib, and abemaciclib has lower selectivity. It is more of a broad spectrum blockade when compared to uh, ribo and palbo. And very important is CDK9 activity. So that's also a reason probably why abemaciclib is active as a monotherapy. Anyways, so the off-target action is higher for abema when compared to ribo and palbo, and this is the free drug delivery that is available to bind to CDK4. It's almost 22 times more. So at clinically relevant doses and after adjustment for differences in potency against CDK4, ribociclib is expected to provide greater CDK4 inhibition than either palbo or abema in clinical studies. Right. So next, let me ask Dr. Nihanti. Dr. Nihanti, this is a question for you. Based on the evidence, what are your thoughts on different mechanism of action resulting in difference in efficacy and safety outcomes with the three CDK4/6 inhibitors?
Good evening, all. Good evening, Chandrakant sir. So, as you have explained in detail, like most of the off targets are quite high for Abema, and moreover, Abema acts more specifically on CDK4, whereas Ribo and Palbo has an extended action on CDK6. So that's one of the other reason for myelosuppression, which is quite common in Palbo and Ribo. Maybe that's the reason we give a 7-day off period. Whereas in abemaciclib, this myelosuppression is not there, but because its specificity to CDK4 and lot of off-target is present, so we do have other side effects like diarrhea and fatigue, which is quite commonly experienced. So safety-wise and efficacy-wise, I think, again, you need to look into the comorbidities of a patient. If a patient has any persistent any altered liver enzymes, or if there's any altered QTC on ECG. So in those cases, I wouldn't prefer ribo as the first choice, sir. In those cases, maybe abema would be my choice of treatment. But if a patient has persistent issues like diarrhea or persistent issues of fatigue, then I would switch to ribociclib or palbociclib.
Any experiences, Dr. Nihanti, of switching one CDK4 to other because of tolerance?
Sir, I have actually done with in a metastatic setting in ribociclib. Upfront patient was started with ribo, even though preliminary ECG was done, but after 6 months of therapy, the patient had a QT prolongation, and even after stoppage and even after dose reduction, there was no reversion back. So in those settings, I've used palbociclib.
Right. Right. So fatigue is an issue with abima and palboneutropenia. So there also you can consider some switching. And if you switch a CDK4 because of tolerance, the efficacy is maintained. Right. Thank you. Thank you, Dr. Nihanti, for that wonderful explanation. These are the guidelines. Category 1 recommendation for ribociclib from the NCCN. This is the recommendation you have. Ribociclib has got both with fulvestrant and aromatase inhibitor in first line. And this is the magnitude of clinical benefit score scale. Very important is in premenopausal women. Ribociclib has got a MCBS of 5, first line 5, subsequent line with fulvestrant. I mean 4. So overall survival in all the 3 trials, Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. So this is very important. 5 is the highest grade, and that is for premenopausal women. So let me ask Dr. Pradeep. Dr. Pradeep, premenopausal women, which is your preferred CDK4 based on these data?
Yeah, of course, that ribo has that in all setting, both pre and post menopausal, they have now that OS benefit is there. But that palbo didn't have that only PFS benefit. And looking into that overall response and its broader activity, selectivity, and so I like to use ribo only in premenopausal. I have broader experience also, both palbo and ribo, but of course the
Right.
ribo has better. Yeah. Yes.
Okay. Thank you, Dr. Pradeep. And this is another interesting subset. Not visceral crisis, but it is a clinically aggressive disease. This is the right choice trial. This is specific, you don't have, you have Mona Lisa 7 that is unique for premenopausal with ribo. Similarly, you have right choice trial for a clinically aggressive disease. In comparison with chemo, the responses were similar and similar time to onset of response in both the arms, but with a better toxicity profile, reinforcing that even in a visceral disease, which is clinically aggressive, even here CDK4/6 can be the standard of care. And that is what the ABC guidelines also say. So let me go to Dr. Sushmita. Dr. Sushmita, this is an important thing. Let's say you have multiple liver mets, lung mets, not in visceral crisis, but a clinically aggressive disease. Any experiences or preferences of CDK4/6 inhibitors in practice, or you would go to chemotherapy?
Oh, no, no. Recently, without visceral crisis, even am I audible?
Yes, you are.
Yeah. So even in absence of visceral crisis or any imminent organ failure or like even aggressive disease, I use only CDK4/6 inhibitor plus hormone therapy as a first line therapy for hormone positive breast cancer, and probably ribociclib will be the better choice. But however, I have used both palbo and ribociclib in this kind of scenario.
Right. So you don't, so we have this right choice trial specifically addressing this question. So that is one evidence that is unique to ribociclib. So this is what we can note from these slides.
Yes.
Right. Thank you, Dr. Sushmita. Now let's quickly go to the quality of life. So this is the summary of quality of life data from the pivotal CDK4/6 phase 3 trials. So what are the domains that you have? Improved quality of life. Okay, you have Mona Lisa 7 and Paloma 3. Maintain quality of life. It's there in almost all the trials, especially in all the Mona Lisa trials, you have maintained quality of life. Clinically relevant improvement in pain score. It's not there with Monarch trials, but it is there with all the Mona Lisa trials and Paloma 3. And then statistically significant delay in time to treatment discontinuation. And more than 10% in pain. Okay, this is also specific to Mona Lisa 7. And then increased worsening, that is especially the diarrhea. Diarrhea has been with Monarch trials. And maintenance of work productivity. So premenopausal subset. Again, that is specific to Mona Lisa 7. So if you look into the quality of life parameters, this sort of question is well answered by the Mona Lisa group of population, whereas the Monarch and the Paloma, I mean, they have not answered each question correctly, especially the diarrhea one, or you have time to treatment discontinuation. So this is sort of a problem with Paloma and Monarch. So these quality of life parameters are sort of well answered by the Mona Lisa trials. So, and again, this is the GI, the diarrhea component with abemaciclib that you have. And this is the MAI. So this is a matched adjusted indirect comparisons of abema and ribo. You don't have a head-to-head comparison, but you have a matching adjusted indirect comparison. So what it says, you have ribo and abema, you have different components. Appetite loss, constipation, diarrhea, dyspnea, fatigue, financial difficulties, insomnia, breast symptoms, all these you have. So this is the quality of life parameters. Again, among indirect comparison, ribo is favored. So this is the summary of time to chemotherapy after study drug discontinuation. Again, you can clearly see that Mona Lisa has a hazard ratio of 0.74, 0.7, 0.69, which is impressive. And this is somewhat about neutropenia, which is predictable. Okay, palbo and ribo have sort of a predictable neutropenia, but they do not translate to febrile neutropenia. Okay, so I would like to ask a couple of things to Dr. Jogmaya. One is diarrhea and fatigue with abemaciclib, which is not there with ribo, that you have to address. And secondly, neutropenia of palbo and ribo. The generic palbo, what I have experienced, is sort of, I feel, lot of neutropenia is there. Like 125 is not possible to give. So you comment on diarrhea and then neutropenia. Diarrhea you compare with abema, and neutropenia you compare with generic palbo, which we are using in the present day.
Actually, with abema, diarrhea is common, but maximum grade 1 or grade 2 diarrhea. Most of the patients, they will have diarrhea. It is well managed with loperamide or things. But fatigue also is important, and almost all patients on abemaciclib, they complain about fatigue. So neutropenia, definitely for palbociclib, I am also a little skeptical in using 125. It is very difficult. Even with the original Pfizer brand 125, actually for Indian patients is difficult. So even if you see that the 21 days and after that 7 days gap is there, from that time itself, it will be always like if the TLC count drops below 1000, then it becomes very difficult to manage. So ribociclib in this setting is actually a very safe drug. We just need to monitor the QTC and the liver function tests. So that is little easier drug to handle, I think. So we have also more experience because until the generic palbo was available, I was using more of ribociclib. Though now with the advent of generic palbociclib, we are using more due to the financial benefits to be passed on to the patients. So I am also finding it's difficult to use the 120 milligram for palbo.
Right. I think that's the important point. With abema dose reduction, diarrhea will come down, and majority of grade 1 to, as you said. And the Indian GI is sort of resistant to diarrhea. This is what we have heard in multiple events. And coming on to neutropenia, generic palbo, it's difficult. You know, I've seen neutropenia going on for months together. So that's the challenge. Okay, so let's go to some special population. The first one is an elderly lady with bone metastasis. Okay, so she's Jaya and she will be on polypharmacy. Drug-drug interactions important. And if you just see the benefit of ribo, it's irrespective of the age. Even in elderly, you have an impressive overall survival difference, and it is independent of age, right? And this is some real world studies, Ribana study, complement study, and the adverse events are also in par with the younger patients. And this is the neutropenia in elderly versus young patients. It doesn't change in the Ribana study. Okay. So, and this is the Monarch 3 and the Monarch 2. So more than 65, if you see the benefit is something towards the right in the Monarch 2 subset. Okay. And then this is the overall survival with palbociclib according to age. And if you see more than 65 in the Pearl study, or even in the Paloma 2, it's more of crossing the unity. Right. So let me go to Dr. Nihanti. Dr. Nihanti, age and CDK4/6 inhibition. Do you have any barriers to offer it?
No, sir. Currently, right now, if patient doesn't have any comorbidities, I think I'm quite comfortable using CDK4/6 even at irrespective of age. Even in elderly, it's quite well tolerated. But again, if it's a bone met, I would look into the number of bone mets and also that is what I would consider. Again, if is it a low burden disease or high burden disease, I would want to check into. Otherwise,
Right, unless and until the patient is very frail, bedridden, I think you would wish to give a CDK4 even in bone mets. Any choice of CDK4, you just saw these studies which I showed, the indirect, the complement and the Ribana studies, suggesting the favorable activity in the of ribo in the postmenopausal. So premenopausal ribo, now this is postmenopausal and elderly. Here also ribo has some indirect comparisons. What are your thoughts on this?
so definitely, sir. In this case, also ribo would be my first choice if the patient doesn't have any comorbidities, like she has well-controlled hypertension and diabetes. I think if you look into the liver parameters and a baseline ECG, if things are quite normal, I think I'll still be comfortable using ribo.
Ribociclib. It is one of the best tolerated among, as we all acknowledged. Thank you, Dr. Niyanti. Okay, this is a 59-year-old lady, grade 3 adenocarcinoma, visceral metastasis to lungs, and the LFTs are grade 2 AST, ALT, bilirubin is more than one time. So sort of aggressive disease. This is the large pooled analysis confirmed survival benefit of ribo in visceral metastasis. Liver mets the hazard ratio is 0.5, and then no new safety signals even in these patients. And there is right choice. It showed that it is better tolerated than chemotherapy. All right. So this is the right choice trial that is suggesting that chemo in the aggressive disease subset, it's chemo versus ribociclib plus osirilin plus NSAI. This is the comparison, and this is the improvement in PFS that you have. And this is the safety. It's much safer to give in the, because if you have a lot of visceral disease, they're frail patients. They may not tolerate the chemo well. And this is the overall health status and physical functional well-being in these patients. So this is Monarch 3, where you can just see the crisscrossing and no significant difference in OS. This is what you can note. And this is the Paloma 2, again, in visceral and non-visceral. Again, in the visceral in Paloma 3, it's the hazard ratio is 0.9. Right. So let me go to Dr. Pradeep. Dr. Pradeep, right choice inclusion criteria with visceral metastasis. So chemo or a CDK4/6 with endocrine.
Yeah, see that patient having visceral disease and visceral crisis. So that will be a little bit different. So if patient is in crisis probably, so in that case, I will start
Chemo.
chemotherapy, of course.
Right.
Otherwise, patient having only visceral disease
Right.
little bit liver enzymes deranged, then definitely that ribo has significant data according to this data. So I will
Right.
choose ribo only in that case.
Right.
And
So
I
again,
think that very rapid in ribo, that rapid
rapid
improvement in
response
symptoms,
is there.
rapid
Correct.
response.
I think right choice answered what you were saying, that the time to response was almost equal to chemotherapy when you could give to these patients with aggressive clinical disease. Right. So we answered in right choice. What is the right treatment? Okay. And now this is the summary slide suggesting CDK4 as standard of care. Differences in on and off target is important. Survival quality of life is important. Ribo is the only drug that has shown overall survival benefit in all the three, Mona Lisa 2, Mona Lisa 3, and Mona Lisa 7. And even in visceral metastasis, elderly population, the OS is there. And then time to chemotherapy initiation is also better. And then the right choice, visceral disease also has. Right. So before I conclude, let me request Dr. Sushmita, final thoughts on ribociclib for all of us.
As we rightly mentioned, the ribociclib, the neutropenia is more less likely, it's easy to use even in the elderly patients. And visceral, the right choice data is only for their only one CDK4/6 inhibitor, that is the ribociclib, where we can avoid chemotherapy even in absence of visceral crisis, but presence of visceral disease. The only things probably we need to keep in mind for the cardiac comorbidities where there is a chances of the only CDK4/6 inhibitor which has a we need to monitor the QT interval, and if the patient which is having a QT prolongation on ribociclib, those patient might be a little difficult to continue ribociclib or might need dose reduction. Other than apart from this, the most common side effects like diarrhea, neutropenia, which is the more problematic in case of where we want to continue CDK4/6 inhibitors, those are more in favor, less in ribociclib. So for patient perspective, ribociclib will be better. Even in the more than 65, the data is there. The patient is well tolerating, and there is no difference of neutropenia or OS regard to less than 65 or so. So taking all this point together, so ribociclib will be more favorable, and having the strong thing that is the only CDK4/6 inhibitor having a waste data. So we should use ribociclib as a first line. The only thing is that we used to use ribociclib more, but now with the availability of generic, probably some of us are using more with the resource constraint setting at the palbociclib generic. Other than this, we are convinced that ribociclib should be used as the first line in advanced or metastatic breast cancer.
Right. Thank you, Dr. Sushmita. I think wonderful thoughts. You summarized everything in a minute. So, well, let's conclude. I would thank Dr. Jogmaya, Dr. Nihanti, Dr. Pradeep, and Dr. Sushmita for your valuable thoughts and sharing your excellent ideas. Thanks again, Dr. Sri Gopal and the organizers for this wonderful opportunity. Over to you, Dr. Sri Gopal. Thank you.
Thank you.
Thank you so much. It was brilliant moderation, sir, as always.
Thank you to our panelists for that excellent discussion. So now we welcome Dr. Rohit Bharat, Country Medical Lead India, Guardant Health, AMEA, Bangalore. Welcome, sir.
Thank you so much for this opportunity. Very warm good evening to all the faculty members who are present here. It's a privilege to be part of this meeting and be presenting on the topic. Just let me allow to share my screen. I'll just pull up my slides. I hope my slides are visible to everyone. Can someone confirm?
Yes, sir, please continue.
Yes, thank you so much. Thank you so much to the organizer, Dr. Sri Gopal, for this opportunity to be presenting on the topic of genomic testing in non-small cell lung cancer. I'm Dr. Rohit Bharat. I'm the Country Medical Lead for Guardant Health in India. And to begin with, we understand that in Asia, Asia shares approximately more than half of the global lung cancer burden. And approximately 21% of the cancer deaths in Asia are due to lung cancer. And if we look at genomically, we are much different from what compared to our Western partners, where we see that in the Western population, there's much more prevalence of KRAS, EGFR, and other biomarkers compared to what we have in Asia. In Asian population, we know that, including India, we know that EGFR has been a predominant driver for driving lung cancer, apart from KRAS, ERB2, and other biomarkers that you see on the screen. And because of this, the recent guidelines as well have updated the kind of molecular testing or the biomarker testing to be performed. Now we have close to 15 biomarkers, which is recommended by NCCN to be tested. But I want to highlight on the few aspects that has been highlighted on the screen, that to test for these biomarkers, the NCCN recommends either a tissue biopsy or a ctDNA-based plasma testing in either in a sequential manner, that either first with tissue and then liquid, or concurrently. So both have to be tested either together or one after the other. And also the guidelines, the recent guidelines also strongly advises for broad molecular profiling with the goal of identifying rare and actionable mutations in these patients. So what does this broad molecular profiling mean? So they have given a definition that a broad molecular profiling, to maximize the detection of any kind of alterations, the panel should cover at least 50 genes. The panel should be more than 50 genes. Not only that, they have recommended the usage of panels with RNA. If you have not tested using RNA, the NCCN recommends now to test with RNA-based NGS testing to maximize detections of fusions. So now, can we test with any panels with more than 50 genes? The answer is no. Because there are multiple kinds of NGS testing, and it becomes important to understand what does the test offer. Because today we have even a 50 gene panel or a 100 gene panel can be a hotspot panel. So these kinds of panels only test for few classes of alterations, but they do not test for all the 4 classes of genomic alterations. And they are not equipped enough to identify genomic signatures in the form of TMB and MSI. So are all NGS equal? No, not all NGS are equal. So hotspot-based panels, even a 50 gene panel, 100 gene panel, is if it's only looking at the targeted regions or looking into just few classes of alterations, will not give you enough detections of biomarker alterations. So the recommendation is always to go for a comprehensive genomic profiling wherever possible, because this is the only class of NGS testing which can cover all the 4 classes of alterations, as well as provide information in the form of genomic signatures of TMB and MSI. And does it really translate into differences in terms of overall detections when you compare a hotspot panel versus a CGP panel? The answer is a big yes. Because if you look at the overall detections for even for common genes, EGFR exon 19 deletions is a very common lung cancer alterations found. But even with a hotspot panel, this alterations get missed approximately 17% of the times. EGFR point mutations 22% of the times. So when you look at the spectrum of all the lung cancer genes that are there, that are recommended by the guidelines, we are missing 1 out of 4 patients when you're just going for a hotspot-based testing. And that's why wherever possible, we should always rely upon a comprehensive, good validated comprehensive genomic profiling to assess for alterations. The second recommendation by the NCCN was to add RNA. So how does RNA actually improve overall fusion detection? So this was the data by MSKCC, where they used the MSK impact panel on more than 2,500 lung cancer samples. And what they found out was when you added RNA along with your DNA, the overall detection of actionable alterations, RNA-based actionable alterations, increased by 13%. And that's a big number. Not only that, even like for detections of complex alterations, RNA is a much better analyte compared to DNA. For example, MET exon 14 skipping, another common alteration in lung cancer, is detected much better by RNA compared to DNA, where the overall detection is more than 3-fold better when you compare an RNA-based assay for MET exon 14 skipping compared to a DNA-based assay. So having RNA along with your DNA-based assay is the way to go forward to maximize detection. We covered what kind of panel to be used, as well as what is the recommendation, but what modality to go for, tissue or liquid. Tissue has been a gold standard, but we also know that tissue has been an issue in lung cancer. And there are 2 major issues that we face predominantly when we go for a tissue-based testing in lung cancer. First is the rate of successful NGS testing being able to be performed. Because if you look at the rates of successful tissue NGS, it greatly depends upon the kind of biopsy being performed. where we have seen that core needle biopsy has one of the poorest success rates of approximately 40%, where you have excisional biopsy, the very high success rate, but it's not feasible everywhere. So in overall, what we look at is that 1 out of 4 patients again is not able to get a molecular profiling done because of inadequate quantity of tissue not being sufficient, and which is a big number. Not only that, another challenge that we face with tissue-based NGS testing is the heterogeneity. Heterogeneity can be in the form of intratumor heterogeneity, that is the heterogeneity within the tumor itself, intertumor heterogeneity, that the differences between the primary as well as metastasis, as well as the heterogeneity or a temporal heterogeneity, the heterogeneity that gets acquired upon resistance development. So to address all of this, we have different solutions that can be available today. So to address the first aspect in terms of tissue-based NGS, the quantity not being sufficient, I see hands being raised. Is there any question? Dr. Avni? I can reserve the questions for the later end of the session. So yeah, as I was telling, to address the quantity not being sufficient, we have different solutions, as well as to address the heterogeneity aspect, we have different solutions available today. To address the quantity not being sufficient, I want to introduce the Guardant 360 tissue panel, which is a multi-omic panel and the first multi-omic panel available, which assesses for DNA, RNA, as well as even epigenomics. So the current panel, Guardant 360 tissue, is powered by the Infinity platform, which covers more than 700 genes for DNA-based assessment, amplifications for 20 genes, DNA-based fusions for 28 genes. For the epigenomic component, we have promoter methylation assessment for 47 genes. Genomic signatures are captured in the form of TMB, MSI. RNA panel, a very comprehensive, one of the most comprehensive RNA panel available today for 367 genes. AI-based PD-L1 included along with this product. Not only that, in terms of specificity and sensitivity, the panel maintains a very high sensitivity and specificity of approximately 100% and a very high sensitivity of more than 95% at 1.3% VAF. But how do we address the challenge that we face with low quantities of DNA or the quantity not being sufficient? So in terms of sample requirement, the Guardant 360 tissue requires the least amount of tumor DNA or tumor specimen compared to industry standards. If you look at the industry standards, if you are sending slides, most of the labs require at least 10 slides, but only Guardant 360 tissue can work with 6 slides. And also in terms of surface area requirement, the industry standard for surface area assessment is at least 25 millimeter square. But Guardant 360 tissue is optimized to work with just 2 millimeter square surface area. And in terms of tumor content, there's no other lab which accepts samples below 20% tumor content. But with Guardant 360 tissue, we are able to process samples at 5% tumor content. And this drastically improves the overall success rate for your tissue-based NGS testing. So this is the data that we have currently, where we have been able to process more than 97% of the samples with tumor content above 5%. Whereas the success rate for other labs has been around 60 to 70% or maximum 80%. And because the platform requires such low quantities of DNA, we are also able to assess materials from sources other than standard biopsy. So cytology blocks prepared from fine needle aspirate or pleural fluid or from core needle biopsy are now being able to be processed because of the low tumor specimen requirements. And here we showcase this performance of these samples where we were able to process all these samples at a very high success rate. This is the data that was published in AACR 2025, where we published the analytical validation of the platform, where we took samples from different indications with different tumor purity. And if you look at the DNA success rate for both DNA as well as RNA, for freshly extracted samples, the success rate was above 98% for DNA and above 96% for RNA. Even for archival tissue, which could have been more than 1.5 years old, the overall success rate for DNA was 98.3%, as well as even for RNA, the success rate was 91%. And also with specimens with very low surface area or less than 5 above 5% tumor content, the success rate was above 90% or almost 100% in most of the cases. And this is despite requiring low quantities of DNA, the sensitivity and specificity is not compromised. If you look at the PPA and NPA for various classes of alterations, is above 95% for the different classes of alterations, including RNA-based detection and for promoter methylation. Just to showcase an example, here we have a specimen, a tissue biopsy specimen from a bone fracture site. The tumor content available was just 5%, where we were able to detect an actionable fusion in both DNA as well as in RNA. So a targetable alteration being detected with 5% tumor content, even from a difficult to process specimen like a bone specimen. So that should give you the confidence on the ability of the platform to process samples at low quantities of DNA. To summarize, to address the challenge of not being able to process most of the samples for molecular profiling, Guardant 360 tissue is now able to process specimens with low quantities of tissue as low as 5% tumor content. Not only that, it identifies clinically relevant genomic alterations, which includes mutations, amplifications, fusions, genomic signatures like TMB and MSI, and demonstrates a very high analytical accuracy of more than 95% in identifying clinically relevant genomic alterations. So the first challenge, where you had the challenge of not having enough quantities of DNA, now you have a solution available with Guardant 360 tissue, where you can process samples with as low as 5% tumor content. Now, to address the aspect of heterogeneity that we face with tissue-based testing, we always know that liquid is much better in capturing heterogeneity. And Guardant 360 liquid, we have been the pioneers in the space of liquid biopsy. We were the first liquid biopsy to get an FDA approval. And we have been validated with more than 600 publications till date. Not only that, we also demonstrated through various studies that liquid is actually non-inferior to tissue in terms of detection for biomarkers. This was a Nile study in newly diagnosed lung cancer patients, where we detected the overall detection capability for both tissue as well as liquid. Even though we had a very high concordance, there were certain alterations that were better detected using liquid, and there were certain alterations that were detected only using tissue. So hence, combining both tissue plus liquid is definitely the way to go forward to maximize the overall detection for any biomarker. Not only that, we again saw from the PEN2 study where we had a very high failure rate where you go for only for a tissue-based testing that can be mitigated using liquid biopsy. And the overall detection when you combine tissue plus plasma is much higher compared to just going for tissue-based testing or liquid-based testing. Liquid biopsy has also proven its mettle in terms of detecting resistance alterations, where we have been able to showcase that resistance alterations are much better captured using liquid biopsy compared to tissue biopsy. Where again, in breast cancer, again, we have seen the recent data from Serena 6 trial, where we have showcased that resistance alterations in ESR1, the clonal alterations are much better captured using liquid biopsy compared to a tissue biopsy. With that, I wanted to introduce the new panel of Guardant 360 Liquid, which is on the Infinity platform. So this panel is also capturing more than 700 genes, 740 genes, which includes amplification for 90 genes, copy number losses for 14 genes, DNA-based fusions for 27 genes, promoter methylation for 47 genes, TMB, MSI, and apart from that, a host of other supplementary features are now available within liquid biopsy. And some of these features are relevant for lung cancer, which we'll be discussing in short while in the subsequent section. And despite this, despite having a very comprehensive panel for assessment, we still remain on the most sensitive platform for liquid biopsy. The threshold for positivity is 0.001% BAF, which is, as I mentioned, is one of the most sensitive platforms for liquid biopsy testing available today. But with liquid biopsy, the challenge for physicians had been whether if a patient is coming out to be a biomarker negative, the confidence that it's actually a true negative or false negative was low. And that's where now to address and mitigate that problem, we have this feature called the confidence score that the patient is biomarker negative. So this feature is available for CRC as well as lung cancer specimen samples, where we assess for all the recommended guideline biomarkers and we provide a confidence score. So if based on the confidence score, you can take a judgment if the patient is actually truly biomarker negative or it's a false negative. So the confidence scores would be present in bottom of the report, where a confidence score of less than 90% indicates that there's a 10% probability of some of the other alterations being missed. So in those cases, some additional testing would be definitely recommended. Confidence scores above 90% indicates that predominantly you have covered everything. The possibility of missing out on any alterations is much lower in those cases. Apart from this, now we have launched a molecular lung subtyping feature available with liquid biopsy. We understand that NSCLC is a very heterogeneous disease, and patients, those who undergo initial treatment, can undergo biological transformation as an acquired resistance mechanisms. And upon progression, it's not always feasible to have a tissue-based histological confirmation for the subtyping to be available. So now liquid biopsy could be an option in these cases, where we have already demonstrated that methylation-based detection of lung subtyping is now feasible. This was early data that to showcase that we are able to differentiate between just using liquid biopsy and methylation signatures that we assess. We are able to differentiate between subtypes of lung adenocarcinoma and squamous cell carcinoma. But with a new feature which is incorporated into the Guardant 360 liquid, we are able to differentiate between 3 subtypes. That includes lung adenocarcinoma, squamous cell carcinoma, and small cell carcinoma. So this is the algorithm that the sample, the specimens are run through, where we are assessing for methylation signatures for over 9,000 differentially methylated regions. So based on these DMRs, we classify, we send the sample through a binary classifier, and the samples get processed and analyzed for the proportion of lung adenocarcinoma, squamous cell carcinoma, and small cell carcinoma present in the sample. This algorithm was validated, where we validated this algorithm on an independent cohort of more than 230 samples, where if on the left side, this is the true histological subtype of the samples, and on the bottom, you have the predicted subtype. So if you look at the overall correlation, we see that the overall accuracy for detection for lung adenocarcinoma was 92%. For squamous cell carcinoma, it was 82.8%, as well as for small cell carcinoma, it was around 81%. And this is how the current report would report the various subtypes now available through a liquid biopsy. So you have the proportions of adenocarcinoma signatures being present for small cell carcinoma. So this is a supplementary feature now available with Guardant liquid biopsy, where you can, based on the signatures that you see, it's meant to be as a nudge for you to do additional testing. For example, if you see a small cell signature present in the sample and you have not validated histologically, so that's a nudge for the physicians to get a better understanding about the patient's histological confirmation. And again, the other feature available is a molecular tumor typing feature, which can be very relevant in cases of cancers of unknown primary. So currently, Guardant 360 liquid biopsy is able to differentiate and identify, based on the epigenetic signatures, 14 different cancer types. And it becomes very relevant in cases of cancers of unknown primary, where we'll be able to provide, based on the epigenetic signatures, what is the tumor of origin for that cancer. And for example, this is a sample report where we've been able to predict the primary prediction for this sample has been lung. From a real world scenario, if I want to showcase, this was a recent report where the physician was confused between the actual tumor of origin. So it was sent to us as a cancer of unknown primary. And based on the liquid biopsy report, we were able to predict that the cancer was of the lung origin. And based on this, the physician acted upon it, and the physician was able to achieve desirable results for this patient. So this is how liquid biopsy is transforming not only the overall molecular profiling, but also supplementing with additional features towards a better understanding of the tumor biology for those patients. With that, I conclude this session, and I thank all the faculty members for this patient hearing, and I am open to address any questions that you may have. Thank you.
That was a wonderful session, Dr. Rohit. Thank you. I would like the tech support team to stop the recording for the next session for his talk and to take this webinar forward.
So hope my slides visible and I'm audible.
Yes, sir.
So I'll be talking on the leveraging T-cell potential in managing esophageal carcinoma. So slides are not moving. Give me 1 minute. Yeah. So about esophageal cancer. So in India, this is the third most common cancer among Indian male after oral cavity and lung cancer. And considering both sex, this esophageal cancer ranks fifth most common cancer. If you look at the male versus females, so it is more common among Indian men compared to the women, 2.5 times more common among Indian men. And if you look at the histology, esophageal squamous cell cancer is the most common type. It comprises about 85% of the all esophageal cancer. So again, among the esophageal squamous cell cancer, about 40% are diagnosed in the de novo metastatic stage. And the survival, when we look into this cohort of patients, it is very dismal. In the stage 4 esophageal squamous cell cancer, the survival, the 5-year survival is less than 10%, so about 5 to 6%. Now, looking into the histology, the esophageal squamous cell cancer, as we discussed, is about 85%, and mostly it is seen in the upper and middle third of the esophagus, more common in the younger population, carries very poor prognosis. Now, let's look at the data of tislelizumab in managing esophageal squamous cell cancer. This is the Rationale 306, which looked into tislelizumab plus chemotherapy versus placebo plus chemotherapy in the first-line management of advanced metastatic esophageal squamous cell cancer. So this Rationale 306 was a global trial, and it was studied in 649 patients in 162 sites of 16 countries and 4 geographical regions. So the Asia, Europe, Oceania, and North America. And we can see the interesting data is that in this Rationale 306, the Asian population was the largest. That was about 75%. And it was a phase 3 global randomized placebo-controlled trial. And it included the de novo advanced metastatic esophageal squamous cell cancer, not received any prior systemic therapy. The randomized 1:1 into tislelizumab 200 mg 3 weekly plus chemotherapy versus placebo plus chemotherapy. The chemotherapy backbone used here was platinum plus fluoropyridine, or the second chemotherapy was platinum plus taxane. The primary endpoint in this 306 study was the overall survival in all comers in the ITT. And the secondary endpoint was OS in PDL1 more than 10% subgroup, or PFS, objective response, duration of response, quality of life, and safety. So you can see the primary endpoint of OS in all comers. You can see the hazard ratio for OS was 0.66, and median OS, we can see the delta value of 6.6 months, which is very, very interesting and very hard to find that the delta for OS is 6.6 months in any of the IO chemotherapy trial, particularly in this esophageal squamous cell cancer patients. So the primary endpoint of overall survival benefit was achieved in this trial, which was statistically significant and clinically meaningful. And if you look at the secondary endpoint, the OS benefit in the PDL1 subgroup, the PDL1 more than 10%, the hazard ratio for OS was 0.72, and the PDL1 less than 10%, the hazard ratio again was 0.62. So irrespective of PDL1 expression status, the OS benefit was statistically significant and was observed regardless of PDL1 positivity score. Now, if you look at the OS benefit in this 306 trial, based on like irrespective of the age, sex, smoking status, the chemotherapy backbone, the ECOG PS01, or the geographical status, so irrespective of all these subgroups, there was a consistent OS benefit with this tislelizumab plus chemotherapy. Now, if you look at other secondary endpoints like PFS, objective response, so you can see the Kaplan-Meier curve for PFS, very widely separated curve, and the tail end also very well separated. The hazard ratio for PFS was 0.62, the p-value significant. So definitely there is a significant PFS benefit. And objective response also you can see here with the tislelizumab plus chemotherapy was 63% versus only 42% with chemotherapy alone. And if you look at the duration of response, which was 7.1 month with tislelizumab plus chemo versus 5.7 month with placebo plus chemo. So significantly improved PFS as well as improved the tumor response and the duration of response with tislelizumab plus chemotherapy versus chemotherapy alone. And if you look at the safety profile, that the grade 3 higher toxicity was almost similar with Tislely plus chemo versus chemotherapy. And grade 3 higher immune-related adverse events were about 8% in the Tislely arm versus 1% in the placebo chemotherapy arm. So the treatment-related toxicity leading to discontinuation was 31% in the Tislely chemotherapy arm and 22% in the placebo chemotherapy arm. So it was well-tolerated combination. If you look at the second-line second-line management of metastatic esophageal squamous cell cancer, this is the Rationale 302 trial, which compared tislelizumab monotherapy versus chemotherapy. So here they have taken the advanced metastatic esophageal squamous cell cancer post-progression to first-line systemic therapy. In the second-line setting, they have compared tislelizumab 200 mg every 3 weekly versus the chemotherapy. So the primary endpoint was overall survival in all comers, and the secondary endpoint was overall survival in the PD-L1 TAP score more than 10%, PFS, objective response, duration of response, quality, and safety. If you look at the primary endpoint, the overall survival in all comers, the delta value was, and the hazard ratio was 0.70, so which was statistically significant. If you look at the secondary endpoint, PD-L1 TPS, TAP score more than 10%, the delta value for OS was 3.5 months. So of course, in the PD-L1 TAP more than 10%, the delta was more prominent and more pronounced. Again, the hazard ratio was 0.54. So the overall survival benefit was statistically significant and clinically meaningful with this tislelizumab monotherapy. If you look here in the forest plot, in the all across subgroups, irrespective of age, sex, smoking status, chemotherapy, or the region, Asian or non-Asian, so we can find there is a consistent OS benefit with the tislelizumab monotherapy. Now, if you look at the other secondary endpoint in this second-line setting in the esophageal squamous cell cancer, with tislelizumab, there is a significant PFS benefit with hazard ratio 0.83. We can see the tail end of the PFS curve is well separated. And if you look at the objective response rate, the ORR with tislelizumab was 20%, which was about 10% with chemotherapy. So doubling of the objective response with tislelizumab. And the duration of response again was higher, was 7.1 month with tislelizumab versus 4 months with chemotherapy. Looking at the safety data of tislelizumab monotherapy in the second line, we can see the grade 3 higher treatment-related toxicity was significantly higher in the chemotherapy arm compared to tislelizumab. We can see the grade 3 higher toxicity was about 18% with tislelizumab, which was 55% with chemotherapy. So almost 3 times higher toxicity was seen with chemotherapy compared to tislelizumab monotherapy. The treatment-related toxicity leading to discontinuation was 2 times higher with the chemotherapy arm compared to tislelizumab arm. Now, let's dissect the data and see how the second-line tislelizumab gave the benefit as per the PD-L1 scoring. If you compare the TAP score versus CPS score versus TC score, so the concurrence rate between all these testing modality was similar. The concurrence rate was higher, and we can see from this table that irrespective of the TAP score or CPS score or TC score, so irrespective of this score, the objective response rate benefit was found across all subgroups with tislelizumab monotherapy in the second-line setting. Now, again, looking into this table, we can see that the overall survival benefit was seen across all PD-L1 subgroups, be it irrespective of TAP score or CPS score or TC score. So there was concordance between this TAP, CPS, and TC score, and the OS benefit of tislelizumab was found irrespective of this PD-L1 score. Now, looking into the indirect comparative data, although these are cross-trial comparison, the first-line management of esophageal squamous cell cancer, if you see the tislelizumab plus chemotherapy or pembro plus chemo or nivo plus chemo or toripalimab chemo or sintilimab chemo, pembrolizumab or serplulimab chemo, you can see here. So in all comers or in PD-L1 positive cohort, so even in all comers, the hazard ratio with tislelizumab plus chemotherapy was 0.66. The p-value was significant. If you look at the delta value, it is almost about touching 7 months, which was quite higher than any of other trial data. So hazard ratio was very promising, p-value significant for overall survival in all comers, and the delta value was very, very prominent. And if you look at the PD-L1 positive cohort, again, the median OS hazard ratio was 0.61, p value significant, the delta value of 6.8 month, which was not even seen in the data with pembro chemo or nivo chemo or any other chemoimmunotherapy combination. So median OS benefit with tislelizumab plus chemo was seen in all comers as well as PD-L1 positive cohort. And the delta value was almost highest with this tislelizumab chemotherapy compared to any other chemoimmunotherapy combination. Now, let's look at the second line management of this esophageal squamous cell cancer. So in the second line metastatic esophageal squamous cell cancer, tislelizumab monotherapy has been found to be like giving better OS and PFS compared to pembro or nivolumab. You can see here from this data. Now, looking into the gastric cancer, this is the epidemiology of gastric cancer in India. So gastric cancer scores about ranks 5th position in the among Indian males. And if you look into the gastric adenocarcinoma, so it has two major histologic types. So intestinal type, which are mostly well differentiated, and the poorly differentiated type or diffuse type, which are very aggressive and carries poor prognosis. So this is the data of tislelizumab plus chemotherapy in the first line management of advanced metastatic gastric adenocarcinoma, the RATIONALE 305 trial. So that is again phase 3 randomized placebo-controlled trial that have incorporated the advanced metastatic esophageal G junction or gastric adenocarcinoma. So that is randomized 1:1 into tislelizumab plus chemotherapy versus chemotherapy plus placebo. The primary endpoint was OS in the PD-L1 positive cohort, that is PD-L1 more than 5%, and also in the all-comers ITT population. So here, this is the patient baseline characteristic. We can see the PD-L1 more than 5% was seen in about more than 50% of patients. And the gastric primary in this study was about 80%. The G junction primary was about 20%. The Asian population constituted about 75% in this study. Now let's look at the primary endpoint of overall survival. Here we can see in all patients, the hazard ratio for OS was 0.79. And you can see in the PD-L1 tap more than 5%, that is the PD-L1 positive cohort, the hazard ratio for OS was 0.71. In both the curve, we can see there is a clear separation of curve until the tail end also very well separated. So in all patients and also the PD-L1 tap score more than 5%, the OS was improved with tislelizumab plus chemotherapy versus placebo plus chemotherapy. Now looking at the secondary endpoints, the PFS and the tumor response. If you look at the first curve, the PFS, the hazard ratio for PFS was 0.78. Again, the curve is very well separated. So there was a significant PFS improvement with tislelizumab plus chemotherapy versus placebo plus chemotherapy. And also the objective response rate, you can see here that the objective response rate was quite higher, significantly higher with tislelizumab plus chemotherapy. Sorry. Now looking at the safety summary. So you can see here the treatment-related adverse events leading to treatment discontinuation was 16% with tislelizumab plus chemo and was 8% in the placebo plus chemotherapy. Now looking at the grade 3 hair toxicity, which was 53% in the tislelizumab plus chemo and 49% almost similar between the two arms. So tislelizumab plus chemotherapy was found to be a manageable safety profile with most common toxicity was consistent with safety profiles of individual study components. Now this is the cross-trial comparison of this tislelizumab chemotherapy versus pembro plus chemotherapy versus nivo plus chemotherapy. So what we have found that in the first line management of gastric or G junction adenocarcinoma, overall survival seems to be better with tislelizumab other than other PD-L1 inhibitors like pembro or nivolumab with chemotherapy combination. You can see here the median OS of 16.4 months with the tislelizumab plus chemo, which was 15.7 with pembro chemo and 14.4 with nivo chemo. Although this is a cross-trial comparison, but we can see the delta value looks more promising with tislelizumab plus chemotherapy. Now this is the guideline recommendation in the esophageal cancer management NCCN category 1 recommendation for tislelizumab plus chemotherapy in PD-L1 CPS more than 5 and category 2A recommendation in PD-L1 CPS 1 or more. In the second or subsequent line management of esophageal squamous cell cancer, tislelizumab monotherapy is the category 1 recommendation. For gastric adenocarcinoma management, the tislelizumab plus chemotherapy is the category 1 recommendation for PD-L1 CPS more than 5 and it is a category 2 recommendation for PD-11 CPS more than 1. Now, summarizing the data, the tislelizumab clinical trial summary. This is in the first line management of esophageal squamous cell cancer. Tislelizumab plus chemotherapy has shown statistically significant and clinically meaningful improvement in overall survival, as well as improvement in tumor response compared to chemotherapy alone. In the second line management of esophageal squamous cell cancer, tislelizumab has shown statistically significant, clinically meaningful improvement in overall survival, as well as the tumor response compared to chemomonotherapy. In the first line management of gastric or G-junction adenocarcinoma, tislelizumab plus chemotherapy has shown statistically significant, clinically meaningful improvement in overall survival, tumor response compared to chemotherapy alone. So thank you everyone for patientful hearing. Over to organizers.
Thank you for this informative session, sir. I would like the tech supports team to again stop the recording for the next session. End of today's enriching sessions. I invite Dr. Sri Gopal to deliver the closing remarks and conclude this webinar. Sir, you're muted, sir.
Yeah. So thank you, Sudeep sir, for such a elaborative discussion. And as now we come to the close of CME, so first and foremost, I would like to thank all our distinguished speakers and experts for sharing your valuable time, knowledge, and insights with us today. We hope today's learning will translate into better outcomes for our patient. My heartfelt thanks to all participants for your active participation. We're also grateful to our organizing committee, all supporting staffs, sponsors for making this event smooth and successful. And thank you once again to all of you. We look forward to see you at our next CME event, and best wishes to all of you. Good night.
Thank you, sir. Thank you, everyone, for joining. Thanks to my colleague Umang and Avni, who has put all the hard work to make this webinar a successful one. And thanks to the support team. Good night, everyone. Good night, sir.
Thank you.
Support team, close the meeting.